Let me get started here. I'm going to be discussing two things with you today. I'll be discussing in the morning pain control, which is one of the most important things that we do as dentists. Some of you will go on in your dental practices after you graduate and specialize in pediatric dentistry, endodontics, periodontics, oral surgery. Some of you may go and do implants somewhere. Or you're a general dentist. You do everything. And the one thing that ties everybody in dentistry together, you're the best implantologist, you're the best surgeon, the best pediatric dentist, is local anesthesia. You cannot do good dentistry. You can do dentistry. I don't think anybody here would want to do dentistry on a patient without local anesthesia, because I'm hoping that we don't want to hurt people. And I know that's true. We don't want to hurt people. And the drugs that we're discussing here this morning, are in all of medicine the safest and the most effective drugs for pain control. There's nothing that we use in medicine that is safer than local anesthetics for pain control. There's nothing we use that is more effective. Now, I am a dentist. I graduated dental school in 1969. I'm from New York originally. And after I graduated dental school, I did a medical residency in anesthesiology. So my qualifications, even though I am a DDS, I'm not an MD, I'm a DDS, I have the medical qualifications of an anesthesiologist. And in fact, during my residency at this hospital in New York City, you do anesthesia. You put people to sleep. And whether the surgeon is an oral surgeon taking out third molars, whether the surgeon is a cardiac surgeon doing a bypass, an orthopedic surgeon replacing a hip, it doesn't matter. General anesthesia is what I do. I put people to sleep, somebody does a procedure, and then I get paid for waking the patient up. Okay? I don't get paid for putting them to sleep. I get paid when they wake up. Think about that one. So again, with the drugs that we have in medicine, I'm going to try to explain to you how effective these drugs are. Now, local anesthetics, how important are they? And nice shoes. Excellent shoes. Excellent. These are probably the people who live very close to the campus. Right? The ones who live closest are the ones who always come in last. I am approaching this, obviously, from an American perspective. And Jennifer D. St. George, the lady on the screen, she's been giving lectures. She's not a dentist. She is a practice management consultant. You hire her as a dentist to help make your practice more efficient, make more money. And she published an article in a magazine called Dentistry Today. She published this article about 2 years ago. And it emphasized something. It's how does a patient evaluate their dentist? I think some of the faculty at dental schools would say, we want good quality dentistry. Now think about this. Does a patient, if I were to move here to Guatemala and I'm a lay person, I move into a neighborhood here and I need a dentist. I go to my next door neighbor and I ask them, do you have a good dentist? Now, what is a good dentist to a patient? Stanley, you should go to see Dr. Alfaro. You're a general dentist now, okay? You should see Dr. Alfaro. You know why? Because his margins are only 2 angstrom units. Does a patient care about margins? Of course not. Now, what patients care about, well, we'll see in a moment. This is the list, a list of the top 10 things that patients consider when seeking a dentist. And some of them are pretty obvious. I'm not going to go over these top, these number 10 is good sterilization, prompt appointments. I look at number 6. I'm a professor. I've been teaching for 33 years. And I don't know if your instructors tell you this in lectures, but don't be afraid to ask a question. There's no such thing as a stupid question. Now, there are. There are some very stupid questions. Now, even though your classes here are small, you only have theoretically 20. We lose a couple, just like in the States, we lose students. Every class has one student. You understand what I'm talking about? There's one student in your class who will always ask that question. You know, Rodrigo? Okay. So a dentist who listens, allows questions, treats dumb questions with dignity. I don't do that. You ask me a dumb question, you're in trouble. Okay. Now, patients like when a doctor does a good exam. They love when you run on schedule. They love that. Now, let's look at the next couple of them. Number 3, your staff. Your staff are going to be so important to you when you graduate. By the way, I'm speaking to you as though you are still students, and in actual fact, we all are. You could have graduated this school 25 years ago, 10 years ago. We're still learning, so theoretically we are lifetime students. But the people who are in practice understand that a very important part of that practice, from patient satisfaction, is the people who work with you. When that patient calls your office up, the receptionist, if that's a very nice person and they handle the phone calls well, that's a good start. If they're very, very nasty, nobody's going to come to your office. When the patient comes into the office, they want a nice environment. They want people who are friendly. Okay, that's the third most important thing. The second most important thing is a dentist who does not hurt. Now, obviously, there's a reason for me showing you this, because the number one reason, the number one thing that patients look at when looking for a new dentist is, does Dr. Malamed give good shots? Patients use that term. We don't use that term. Shots, injections, local anesthetics. Does the doctor give good injections? Now, it doesn't mean they work all the time. It means they don't hurt when you give them. And that is the single most important thing, which again is our discussion right now, local anesthesia. I'm going to show you a little bit of a video, and I have all these videos I like to show. They're funny theoretically, and the problem is that a lot of them are funny in English, and some things may not translate well, so let's try this, okay? This is maybe an example of why patients do not like going to their dentist. Turn the lights down.
When I was younger, just a bad little kid, my mama noticed funny things I did, like shooting puppies with a BB gun. I'd poison guppies, and when I was done, I'd find a pussycat and bash its head. That's when my mama said,
"What did she say?"
She said, "My boy, I think someday you'll find a way to make your natural tendencies pay. You'll be a dentist. You have a talent for causing things. Hey, son, be a dentist. People will pay you to be inhumane. Your temperament's wrong for the priesthood, and teaching would suit you still less. Son, be a dentist. You'll be a success."
Here he is, folks, the leader of the class. Watch him suck up that gas. Oh my God! He is a dentist that he'll never ever be any good. Who wants that teeth done by the Marquis de Sade?
Oh, that hurts! Wait, I'm not numb!
Shut up. Open wide. Here I come. I am your dentist, and I enjoy the career that I picked. I'm your dentist, and I get off on the pain I inflict. I thrill when I drill a bicuspid. It's swell, though they tell me I'm maladjusted. And though it may cause my patients distress, somewhere in heaven above me, I know that my mom is proud of me. Oh, mama? 'Cause I'm a dentist, and the sick fail. Say ah. Say ah. Say ah. Now spit.
I've always wanted to take that water syringe and do that, you know, just always wanted to do that. Okay. This afternoon, I will be discussing medical emergencies, and unfortunately, there is a correlation between local anesthesia and medical emergencies. I made the comment that local anesthetics are the safest and the most effective drugs in all of medicine for pain control. The point is they're still drugs. Now, I'm not going to go into discussions of problems from the local anesthetics today because they're rare. The problem is that most medical emergencies that occur in our profession are produced by fear. Fear-induced emergencies. When somebody is afraid of whatever you're doing, whatever it may be, things go wrong. For example, happy people do not faint. Scared people faint. People who have asthma in a dental office, if they're scared, they have an asthmatic attack. If they're not scared, they don't. People with angina, if they're scared, have chest pain, and if they're not scared, they don't. Most medical emergencies that again, I'll go over the entire list with you this afternoon. 75% of all the emergencies that we see in dentistry are produced by fear or the lack of pain control, lack of good anesthesia. Now, first things first. The most common medical emergency in dentistry is fainting. We're going to discuss it this afternoon. Fainting, syncope. Fainting can happen anytime. It is more likely to happen in a dental office when the patient is most scared. If you do a survey of the dental population, the thing that scares them the most is getting an injection. Now, you're going to hear this from your patients perhaps. The patient comes in to see you. Dr. Malamed, do you have to give me a shot to do this procedure? Dr. Malamed, I hate getting shots, but once I'm numb, I'm okay. They're telling you the injection. I don't want the injection. We have to do it. That's the one thing we have to do. The only option we have to using local anesthesia, well, there are two options. One of them is ridiculous, hurting the patient. The other option is general anesthesia, which is not a good option for virtually everybody in this room. Local anesthetics, as good as they are, scare patients because we have to put a needle on the end of it, and in their terminology, we have to stick it in. Now, when emergencies happen during the dental treatment, this is a study that was done, I published this back in 1993. When during a dental visit, at what point in time during a dental visit do medical emergencies occur? 1.5% of the emergencies happen in the waiting room. Think about it. If you're scared of going to the dentist, when you're sitting in the waiting room, nothing's happening. You're safe. Think like your patient. I'm safe. Then the door to the back opens up and you come out. You are the dentist or the assistant. And you come out and you ask, Stanley, hi, I'm Maria. Come with me. Now, I'm not very bright, so I look at Maria and I ask her, where are we going? Oh, we're going to the chair. Now, you see, the dental chair, in America we have the electric chair. And for your patient, it doesn't matter because the chair is where it happens. Whatever they're afraid of, it happens there. So now, we know that, and you've been trained in your dental school career that you don't just walk in, you the doctor don't just walk into the room, the patient's now in the chair, and you don't take a syringe and the very first thing you do is say, open wide, abre la, my Spanish, abre la boca, and give the injection. You don't do that. You sit and I hope you sit and you talk for a couple of minutes, you try to communicate with the patient to sort of help them relax a little bit. But, you know, the one thing you have to do, though, whether, again, you're doing implants or perio or endo or restorative work, you got to get them numb. Got to get them numb. And look at this, 55% of all the emergencies happen during the injection. It wasn't intravenous injection. It wasn't an overdose. It was fear, fainting, most commonly fainting during the injection. 23% of the time, 22% of the time, the emergency happened during the dental treatment. And when it happened during the dental treatment, again, the most common time emergencies occur is during the injection. And we have to give injections. Most emergencies occur because of fear that you either don't recognize or you choose to ignore. Ignoring fear in a patient leads to problems. And that'll be a major emphasis this afternoon. We don't want to have to treat medical emergencies. We want to prevent medical emergencies. You want to graduate from this dental school or go out and have a career in dentistry. You're not an emergency medicine doctor. You're a dentist. You're going to make money doing dentistry. If somebody has a cardiac arrest, you don't make any money. Okay? You don't make any money at all. In America, you lose a lot of money when that happens. So let's discuss local anesthesia. Again, back to my favorite slide. This is my favorite local anesthetic. Can you imagine the size of the needle that would go along with that? Imagine the size of the patient you'd use it on. I mean, Rodrigo, it's a big cartridge. This is what pain is all about. It's a simple concept. The dynamite is the brain, the fuse is the nerve, the match is you. You stimulate the nerve impulse is carried to the patient's brain, and the patient interprets that impulse as an ow. Simple. Take your finger, squeeze the lip, impulse goes to the brain, ow. But you know, it's amazing. Some people don't go ow. You can squeeze as hard as you want, and that person, it doesn't hurt. The same impulse reaching the patient's brain, they're interpreting it differently. And yet you have patients in your offices who are scared, and you pick up your air-water syringe, and you turn the air on, and you blow it near their mouth, and they go, ow. Now, you know and I know that there was no pain impulse there at all. But whatever impulse reached their brain, most people would say it was air. That person interpreted that impulse as being painful because they're scared. A scared person over-responds to stimulation. You give a patient an injection and you start to prepare a tooth. You're cutting on enamel or you're cutting on an old amalgam, which we know there's no pain involved at all in that. None. Zero. Yet the patient's sitting in the chair going, ow, ow, ow. They are interpreting the vibration up here as painful. That's where sedation comes in. That's not real pain. They're interpreting it as pain. And if you sedate the patient, the concept behind, I won't be discussing sedation with you today, but the concept behind using nitrous oxide and oxygen, oral pills, sedative medications, the whole concept behind sedation is to take the patient's mind off of what you're doing. A scared patient is sitting there, and every little click, every little vibration, ow, 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 ow. If you distract them, you know what pediatric dentists do in America? They don't use sedation, a lot of them. They have a television. Here's the child. There's a television set right there. And on that and the kid's got a headset on, and they're watching Ice Age. They're watching Nemo. What are you doing? You're distracting them. Okay? Simple. The child is no longer concentrating on what's happening in their mouth. That's a way of doing it. Pediatric dentists do that. Okay? Nitrous oxide, any other technique, take the patient's mind off of what's going on in their mouth, and that's when you prevent medical emergencies. Very, very simple. That's the concept right there. Now, general anesthesia. I do general anesthesia. I put people asleep. In all honesty, when I said to you earlier, I don't get paid for that. I get paid when I wake them up. Most of the patients, being at a dental school right now, and I've been at the University of Southern California now since 1973, and we have in our dental school in the first floor, we have 3 operating theaters. True, just like in the hospital, 3 operating rooms. One is for oral surgery, one is for implants, and one is for pediatrics. And I work in the implants and pediatrics area. Most of my patients are 3 years old and 4 years old and 5 years old. You know, they're the ones where mom or dad doesn't have much of a dental IQ, and they give the kid, when the kid wakes up in the middle of the night, they give him a bottle of Coca-Cola, or they give him a bottle of milk or something. You know what it is. Nursing bottle caries, milk bottle caries, 20 teeth at the age of 4 years, 3 years that are rotted away. And this little kid needs to have not extractions, but pulpotomies and stainless steel crowns. And little kids do not sit in a dental chair willingly. So we have to put these kids to sleep. And and I have grandchildren who are the oldest. I have 6 grandkids. They're marvelous, but 6 grandkids. But the oldest are almost 6 years old now. And the thought of them having general anesthesia for some procedure that wasn't life-threatening, I wouldn't want to do it. Because I do anesthesia for a living. I put people to sleep with drugs. And by the way, you're going to find out I put people to sleep without drugs. You'll see it later on this afternoon as you fall forward. I wouldn't want to do it because I don't care how good you are. Problems happen. Let me ask you a very simple question. Okay, no, I'll make a statement to you, okay? Nobody ever died while they were still conscious. Think about that one, right? Nobody ever died while they were still conscious. Now, if I am giving you drugs, general anesthesia, and what these drugs do is they depress your brain. They are CNS depressants. They depress your brain to the point at which you lose consciousness. I made you unconscious. Aren't you closer to death? Of course you are. You have to be unconscious to die. I am making you unconscious. I don't care how good I am. I don't care how healthy you are. Once in a while, bad things happen. Okay? Once in a while, we have a problem getting a Macintosh computer to work. Once in a while, okay? It's rare. Last night, right? Today, we got it to work today, but problems happen. I don't want to put my kids to sleep. I don't want to do it. There's a risk. The parent they pay me when I give their kid back to them. Mrs. Jones, because mom is crying. She doesn't want to give me her kid. I don't blame her. Give me the kid, put him in the operating room. Mom goes out there. And when I see mom crying, I feel good because it means mom really cares. And I come out every once in a while because it takes 2 to 3 to 4 hours to do all 20 teeth. And I go out and I tell them everything is fine, everything's fine. And when I call you back, when we're done, and I call you back to get your child, if you hear your child crying, that's good. Crying is good. Why? Because they're conscious. You got it? They're conscious. Pay me. That's... But general anesthesia. Here's the point. Here is the point of this whole concept, of this whole thing. Patients during general anesthesia feel pain. Patients who are unconscious in general anesthesia feel pain. Now think about something. Let's look at this picture right here. This is the anesthesiologist's view of the surgical field. Obviously, this is not dentistry. Obviously. Hopefully not anyway. It's a mandibular canine with a very long root. They're doing an apigo through the abdomen. I come into the operating theater. Now, I'm going to go back into the hospital now, okay? I'm not going to be doing dentistry. I'm going to be doing an abdominal surgery. I'm going to be doing anesthesia for abdominal surgery. I come into the operating theater at 7 o'clock in the morning, and I set up my stuff, get my drugs out. And the patient is brought down to the waiting area at about 7:15. The surgeon is not there. The surgery starts at 7:30. The patient comes into the operating theater. I met the patient last night. I talked to the patient now, and I start an IV, and I give the patient some drugs to relax them. Because they're lying in the operating room, they're scared. So I give them some drugs. A drug like Valium called midazolam, it sedates them. I'm not going to put them to sleep until I see the surgeon there. The surgeons are surgeons. They have their own agenda. They're on rounds, they're stuck in traffic, they're drinking coffee, whatever they're doing, but they're always late. So we wait. Now the surgeon shows up. The surgeon walks into the operating theater, says hello to the patient, walks outside and starts to scrub, and now I start. I take my drugs, intravenous drugs, and I push a whole bunch of, literally just push some drug in. The drug is a central nervous system depressant. I depress the patient's brain to the point at which they lose consciousness. I then give some more drugs. I put a tube into their trachea to maintain their airway. I turn on some gases to keep the patient asleep. The nurses now come in. They put these drapes on the patient. And the only area that you can see is the surgical site, the skin of the surgical site. The surgeon now walks into the operating theater. I'm at the head of the patient over here. The surgeon comes to the side. The surgeon looks at me. I look back at the surgeon, and I give her the nod. The nod means go for it, okay? Go for it. They pick up the scalpel, and they make the incision right there. Blood comes out. The assistant sucks it up. I am telling you, the patient doesn't move, by the way. I am telling you absolute guaranteed fact that when that surgeon made that incision, the patient felt pain. Now, they didn't move for two reasons. One is they're unconscious. Unconscious patients can't move. Number two, I've paralyzed them. I've given them muscle relaxant drugs so the patient's muscles are relaxed. They can't move. So how can I tell you they're feeling pain? Because they talk to me? No, they're unconscious. The only way I know that a patient is alive during general anesthesia is by monitoring their vital signs. I monitor their blood pressure, their heart rate. I monitor the rate of breathing and a lot of other things. So I'm talking about those three things: blood pressure, heart rate, and the rate at which they breathe. Now let's say, for an example, just before the surgeon made the incision, the blood pressure was 100/60. The heart rate was 60. And the patient's breathing 12 times a minute. The surgeon comes in, nod, incision. Blood pressure goes from 100/60 to 110/70. Heart rate goes from 60 to 70. On that anesthesia machine, like on your nitrous oxide machine if you have one, there's a bag. The bag is filled with gas. And when the patient takes a breath in, the bag deflates a little bit. When the patient exhales, the bag inflates a little bit. You can watch the patient breathing. When you make that incision on the patient does this. And the bag deflates a lot. So I'm telling you then the patient does feel pain. Think about it. If I walked over to you right now with a scalpel and made an incision on your belly, right now, well, first of all, I'd be arrested and put in jail for murder. Right? Isn't that what the surgeon is doing? Isn't that what they're doing? They're making an incision. You know what it's actually called? When a surgeon makes an incision, it's actually called the surgical insult. The cold metal against your skin is called the surgical insult. The impulse, pain impulse, goes to your brain. There's nothing here to stop the impulse from getting to the brain. The problem is, or the good thing is, the brain is so depressed the patient can't respond to it. They can't respond to it outwardly. They respond to it physiologically. Increase in blood pressure, bless you. Increase in blood pressure, heart rate. Now, you know what's the problem with that? If I don't have my patient asleep enough, they move. And surgeons are surgeons. When patients move during surgery, surgeons, what can I say? They're surgeons. They throw things. They yell. They say very unprofessional things. Blah, blah, blah. So you know what we do? Before the surgeon makes the incision, we just push a little more. Just to be certain. You push a little more. You know the problem with that is? Most adverse drug reactions are dose-related. The more of a drug you give, the more likely you are to see bad things happen. Take, for example, a very commonly used drug called beer. What is it here, Cerveza? Cerveza. Okay? So in the United States, we call it a 2-beer buzz. You drink 2 beers, you feel it a little bit. Yeah, 2-beer buzz. You drink more, you get a little bit woozy. You drink even more. Excuse me. I almost said she translates that. You drink even more, and you can die. You can die from an alcohol overdose. That's the thing. The more you give, the more problems there are. And for me, to give more general anesthesia to protect the patient from the surgeon doesn't make any sense. Okay, so let's go back one more time, and we have a good surgeon. They're all good surgeons, but a compassionate surgeon. Surgeon walks into the operating theater, the patient is unconscious. I give the surgeon the nod. Instead of picking up the scalpel, they pick up a syringe of lidocaine. It's 1% lidocaine. With or without adrenaline is irrelevant. It's 1% lidocaine with a 3-inch needle on it. This is a man, 3-inch needle. Okay? 3-inch needle. And they take the needle and they place it under the skin, basically parallel, not going in like that, but parallel to the skin. And they put the 3-inch needle under the skin, and then as they withdraw the needle, they inject local. So now, right there, when the surgeon picks up the scalpel and makes the incision, remember, that's lidocaine. No increase in breathing, no increase in heart rate, no increase in blood pressure. Local anesthetics. See, local anesthetics are unique. What they do is they prevent the pain from happening. This patient comes in, your teeth 1 through 32, or you go by quadrants? 1. How do you number your teeth here? 1 to 32. Okay. Tooth number 4 is infected. Tooth number 4 is, or number 5 is infected. Every time that impulse reaches the patient's brain, they go, ow. Okay, they come to see you. You take them out of pain by doing a maxillary infiltration. Maxillary infiltration, you're putting water, local anesthetic, along the nerve. As the anesthetic diffuses in, look at this, the impulses get weaker and weaker and weaker. The pain goes away. And eventually, the pain impulse doesn't reach the brain. You're setting up a local anesthetic roadblock. The tooth is still firing off. The nerve is still stimulated. But you're preventing the impulse from reaching the patient's brain. These are the only drugs in all of medicine that truly prevent pain from happening. Here's the example from earlier today with the arsonist, with the match. What you're doing is you're putting water on the fuse. And when you pick up your handpiece, your scalpel, and you start working, you still propagate the nerve impulse. But the nerve impulse doesn't reach the... Look at him, he's not very happy. See, look at that. He doesn't like that. But the nerve impulse never reaches the brain. It doesn't happen. The pain doesn't exist with local anesthesia. Patient is awake, they're conscious. Best drugs we have in medicine. All right, so what are we doing? Well, we are trying to deposit local anesthetic as close as we can to that nerve. I happen to pick a picture of the hardest nerve to find, the inferior alveolar. For those of you in practice, you understand. That's where the problems happen, right? When you have a problem getting the patient anesthetized, invariably it's in the mandible, and almost always it's mandibular molars. Almost always. Right? It's a very elusive nerve. But what we do is this. We are trying to deposit the anesthetic theoretically within a millimeter of that nerve. And what happens then is the anesthetic drug will diffuse. It diffuses not just into the nerve, it diffuses in every possible direction. It diffuses away from the nerve, it diffuses into the audience, it diffuses behind the screen. But if enough local anesthetic gets into the nerve, we block nerve conduction. As it enters into the nerve, it will anesthetize, it will block the fibers, nerve fibers that are outside, the ones that are most peripheral. So what happens in dentistry is as we inject the local anesthetic, as it diffuses into the nerve, the first thing we notice is soft tissue anesthesia. Isn't that true? When you give an injection in the mandible, for example, yes, doctor, my tongue is numb, my lip is numb, we have soft tissue anesthesia. If you deposit the drug close enough to the nerve, if you do, enough of it diffuses in to block the fibers in the center of the nerve, which are the fibers that produce pulpal anesthesia. Pulpal anesthesia always happens after soft tissue. Soft tissue happens first, then pulp. Everybody has had the experience or will have the experience of a patient in the mandible who has profound lip anesthesia, profound tongue anesthesia. And now you start to treat tooth number 30 or 31, and you're taking out this old amalgam. That's not a test of anesthesia at all. The amalgam comes out. In fact, it comes flying out and hits your glasses and bounces off your glasses. And now when you touch the dentin, the patient screams. You had good soft tissue anesthesia. You did not have pulpal. Very, very simple reason. You injected, instead of being right next to the nerve, you were here. Now, here is close enough to the nerve for the drug to get, for some of the drug to diffuse in. It blocks the outermost fibers, which go to soft tissue. There wasn't enough local anesthetic here to block the innermost fibers, which go to the pulp. In other words, in the nerve, the blood level in the nerve went up here. Soft tissue happened, but it leveled off below the level for pulpal anesthesia. That's it. Soft tissue, no pulp. It happens. It happens, unfortunately, too often, especially in the mandible. Now, what happens? Eventually, the anesthetic diffuses into the nerve. There's now an equilibrium. The amount of anesthetic inside the nerve is the same amount that's outside. And the drug stops entering the nerve. Equilibrium. What's happening out here? Out here, there are blood vessels. And the blood vessels absorb the anesthetic. They take it away. So eventually, there's more anesthetic inside the nerve than there is out. And what happens? The drug now begins to leave. The drug now begins to leave the nerve. Okay, that's how anesthesia stops. Now, what happens is the centermost fibers, the ones that go to the pulps, lose their anesthesia first. You know that. Soft tissue anesthesia occurs immediately. 3, 4, 5 minutes later, pulpal anesthesia. 45 minutes to an hour later, depending upon what drug you're using, they begin to feel it. The pulpal anesthesia is going away. And 5 hours later with some drugs, they go home. 5 hours later, the soft tissue is totally gone. Okay? That's the way the anesthetic drugs work. It's called diffusion. The drugs diffuse into the nerve, the drugs diffuse out. That's how they work. You will probably, or maybe already have, had a patient of yours who came in for a relatively simple procedure. Now, you needed local anesthesia. It's a mandibular tooth, you know, and you needed to get a maxillary tooth. You needed mandible. You needed to get them numb. And you picked up whatever drug you like. Most people in the room, from what I heard yesterday, are lidocaine with epinephrine. Okay, I'll discuss all the drugs in a moment. Lidocaine with epinephrine. 1 hour pulpal anesthesia, 3 to 5 hours of soft tissue. The patient comes in, you do the procedure, you're done in a half an hour, the patient goes home. They go home at 6 o'clock at night. Now, I don't know what time you eat dinner here, probably a lot later than we do in America. But, you know, let's say, for example, I eat dinner at 7 o'clock, which is a lie. I eat dinner at 6 o'clock, okay? So I leave the dental office in America at 5 o'clock at night. Now, at 4 o'clock at night, I got lidocaine with adrenaline. My lip is numb, my tongue is numb. I didn't feel any pain. Doctor, you're fantastic. I go home. Dinner is now being served. That's not true. We always order in. We never cook anymore. We order in from somewhere. But dinner is there. Dinner is delivered. Pizza Hut. Here we go, okay? You know what? My tongue is numb. My lip is numb. And it's numb until 10 o'clock at night. It's a problem, isn't it? You ever have a patient complain to you about that when they come back next week? Doctor, you know, I love you. You're fantastic with giving injections. They don't hurt. They're fantastic. But you know what? I was numb like forever. Isn't there some way that you could make it go away? And the answer is going to be yes. The answer will be absolutely, positively yes. Probably, now I'm talking about in America, probably within 5 years. Probably that means 10 because the Food and Drug Administration, the people who approve drugs, you know. So if I say 5, it means 10. You're going to have in your armamentarium a cartridge of a local anesthetic reversal agent. In fact, the name of the study is the LARA, Local Anesthetic Reversal Agent Study. And what you're going to do now, look, surgeons are not going to want it. Following surgery, you want a patient to be numb for a long time. But the pediatric dentist, the general dentist, if you're doing root planing and curettage, when there's little to no postoperative pain, Wouldn't it be nice to be able to unnumb your patient? Now, what this drug is going to do, here's the problem. You're going to have to inject it into the same place you put the drug earlier. Everywhere except in the mandible, that's going to be easy. In the mandible, good luck. But what it does, it does not make the anesthesia go away like that. It doesn't. What it does is it decreases the duration of soft tissue anesthesia by about 50%. So instead of so the patient comes in at 5 o'clock, the drug will work until 10 o'clock at night. They leave the office at 6. They get home by 6:30, eat dinner by 7. Okay, we can cut that soft tissue until it goes away maybe at 7:30. So we can get the patient's feeling back a lot faster. That'll be probably within 5 or 10 years. We'll have this on the market. Okay, so I want to do two things with you today. I want to discuss this morning. I want to discuss the drugs first, and then the techniques of anesthesia. When it comes to local anesthetic drugs, there are many very excellent drugs out there. Now, from what I've been told, you have, I'm going to show you a slide in a moment, of the available local anesthetics in dentistry worldwide. Depending upon what country you go to, there are variations. These are the only 5 that are available. But some countries may not have all 5 drugs. From what I understand, you have all 5 of the drugs. Now, the combinations with epinephrine and other things may be a little bit different from, again, country to country. But the basics are going to be here. The first thing that you're going to do as a dentist when it comes to, here's what I don't, time out. Here's what I don't want you to do. I do not want you to be a dentist who has only one drug in the office. And you use that same drug on every patient. Because, and that drug usually is lidocaine with epinephrine. Or it might be articaine with epinephrine. It doesn't matter. You have one drug because you love that drug. But you know what? Drugs don't always work on everybody. You know that bell-shaped curve I talked about? How, you know, the alcohol thing? And I used the term 2 beers, 2 beer buzz. Well, you know what? If you take a group of, you'll see this in a moment, take a group of 100 people, and if you give everybody 2 beers, 70% of them will have a 2 beer buzz. Most people respond normally to drugs. 2 beers, 2 beer buzz. But you know what? 15% of your population on 2 beers, nada. Nothing. They need 3, 4, 5, 6, 8, 10 more. You know what we call them? Dental students. Dental students. They're called hypo, H-Y-P-O, hypo responders. That's the way they are. And the other 15% are hyper responders. We also call that with alcohol a cheap date. Now, you're looking at a person who is a hyper responder to alcohol right here. You know what a margarita is? Okay? I get a margarita and I lick the salt on the margarita. My face is in the guacamole dip. Okay? I'm almost unconscious, like general anesthesia. But the point is, drugs don't always work the way they're supposed to. And to have one drug in the office for everything makes no sense. It makes no sense for this other reason. Some patients are going to be in the chair for 15 minutes. And to give them a drug that keeps them numb for 5 hours makes no sense. Other patients are going to have surgery. And 5 hours is not going to be long enough. I want drugs that last longer. So the first thing that you're going to consider is, what is my patient's need today? What am I doing for this patient today in the way of local anesthesia? First thing. After you select the drug that you want to use, I want to use this drug. You go back to the patient, the medical history. Is there a contraindication in this patient to using this drug? The answer for local anesthetics almost always is no, there is none. In other words, yes, it's okay to use this drug. There are very, very few absolute contraindications to using local anesthetics in dentistry. A different consideration is the need for hemostasis. In other words, am I doing a surgical procedure where I need to inject adrenaline, epinephrine, directly into this tissue to minimize or prevent bleeding? Am I doing crown and bridge and I need to take impressions and I want to have no bleeding in the area, for example? That's a separate thing from this, because you do not give an inferior alveolar nerve block and get hemostasis in the mandible. I hope you know that. I always mention this because it's such an obvious thing that sometimes people forget this. Epinephrine, to prevent bleeding, has to be injected directly into the site where surgery is being done. It works on the receptors on the arterioles at the site of injection. So if I am working on tooth number 29, and I'm doing a periodontal procedure, for example, and I need hemostasis, if I give an inferior alveolar nerve block with lidocaine with adrenaline, I'm going to get pain control. But when I operate here, I'm not going to have any control of bleeding. You know that. In order for you to get control of bleeding, you have to deposit the anesthetic with epinephrine directly into the bleeding site. It's a totally separate consideration from the drug you're using for pain control. So what's available out there? Again, it doesn't matter. Country to country, there are some minor variations. But what we're going to do is look at these drugs and say, this is the expected duration of anesthesia. If I inject 70 patients with this drug, they will have anesthesia for about 1 hour. By the way, we're talking about pulpal anesthesia, not soft tissue, pulpal. So you can go in and you can operate, you can cut on a tooth, you can do surgery, you can work. Deep anesthesia, pulpal anesthesia. A group of drugs that provide anesthesia for about 1 hour. We have a group of drugs that provide anesthesia for less than an hour. If I have a child in a chair and he'll be in the chair for not more than 15 minutes, I don't want to give him a drug that keeps him numb for an hour and soft tissue for 5 hours, because he might go out and he might chew on his lip, he might bite his tongue because he's numb, he can't feel it. I want a drug that works fast, is short-acting, and goes away just as fast. Short-acting drugs. Now, I'm a surgeon. I'm making believe. I'm not a surgeon. I'm a surgeon, okay? And I'm doing procedures, whether the surgery is 20 minutes or an hour, it doesn't matter. I want a drug to keep my patient out of pain for the rest of the day. I want him numb not for 5 hours. I want him numb for 12 hours. Post-surgical pain control, okay? And we got them. We have drugs that meet all these criteria right here. Right-hand side of the slide. Big list. Big list. You know why? I'm going back to the United States right now. In the United States, every year, the American Dental Association does what is called, it's a survey of dental practice. They send out questionnaires to several thousand. We have 150-something thousand members of the American Dental Association, 150,000 dentists in the U.S. who belong to that organization. And they probably survey 3,000 or 4,000 every year. And what they get are the characteristics of your practice. For example, in the year 2003, in the general dentistry practice, the patient, on average, is in the reception room for 7 minutes. They're in the waiting room for 7 minutes. The actual treatment time, 44 minutes. On paper, they're down for a 1 hour appointment. They're in at 9 or out at 10. But 7 minutes in the waiting room, 44 minutes of actual treatment time. And that's the important number, the actual treatment time, 44 minutes. We need a drug that provides our patient with profound anesthesia for at least 44 minutes or a little bit longer. Okay? These drugs do it. On average, there are reasons they don't work the way they're supposed to. But this is the drug that I'm going to use, one of those medications, if I have my patient in the chair for up to 1 hour, period. Now, the one thing you notice on all of these drugs, I'll discuss the drugs individually in just a moment. Whether it's articaine, I have them listed alphabetically, articaine, lidocaine, mepivacaine, prilocaine, all of them contain a vasoconstrictor. Most of them contain epinephrine. Some people call it adrenaline. Adrenaline, epinephrine, same thing. But in order for these drugs to provide anesthesia lasting for an hour, we have to add something to them. Epinephrine is the most commonly used vasoconstrictor. Now, if you look at the list carefully, look at the very bottom one. The very bottom one is prilocaine. Now, prilocaine is a drug we call sedating. And most often, sedating contains epinephrine. But sedating 4%, no epinephrine, nothing, and it says here in parentheses, NB, nerve block. If you take prilocaine plain, no epinephrine, and if you give an inferior alveolar nerve block, a Gaugate's mandibular block, I'll mention the PSA, their letters, PSA, the ASA. These are nerve blocks in the maxilla, which I'll discuss in a moment. If you take this drug without epinephrine and give a nerve block with it, you will get anesthesia lasting for up to an hour. Well, let's look at the left-hand side of the slide. Look at the short-acting drugs. I have 2 listed there. I have 2 drugs listed short-acting. Now, short-acting drugs are the drugs that I'm going to use when the patient's in the chair for 20 minutes, maybe 25. That's about it. A short procedure. One drug, one really good drug, 3% mepivacaine. I have 2 drugs listed up there, don't I? The other one is prilocaine. The other one is the same drug on the lower right, same drug. 4% prilocaine, lower right, 4% prilocaine. The difference, on the lower right it says nerve block. If you take prilocaine and you give a nerve block, you get 40 minutes of pulpal anesthesia, up to an hour of pulpal anesthesia. Aha. Take the same drug, prilocaine, and give a maxillary infiltration. 5 minutes. 5 minutes. Nerve block, 40 minutes. Infiltration, 5. So prilocaine plain, no epinephrine, is an excellent drug if you give it by nerve block. It is not such a good drug when you give it by infiltration. We'll come back and discuss that in a moment. 3% mepivacaine. 3% mepivacaine. You know what? Let me throw a brand name. Carbocaine. Scandinest. Polocaine. I'm not sure what the brand. See, that's the problem. Brand names are different from country to country. Mepivacaine is mepivacaine everywhere. 3% plain. 20 to 40 minutes of pulpal anesthesia. 2 or 3 hours of soft tissue. 3% mepivacaine. Now, I want you to listen to this carefully, okay? Especially if you are a general dentist. 3% mepivacaine is the most popular drug when the patient is a young child and the dentist is a general dentist. I'm going to say it a little bit differently. 3% mepivacaine is the most popular local anesthetic in young children when the dentist is not a pediatric dentist. Now, I'll come back and talk about that in just a little while. It's a very nice drug when used properly. Keep that in mind. Very nice drug. On the bottom, so in actual fact, we only have one very good drug for short procedures because the prilocaine plain is not a very good drug for short procedures. On the bottom, we have long-acting. Apparently none. There we go. There were 2 long-acting drugs. Now, I have them listed here as providing pulpal anesthesia for longer than 90 minutes, for longer than an hour and a half. In fact, bupivacaine, which is Marcaine, bupivacaine provides pulpal anesthesia lasting for up to 3 hours. But that's not the important thing about the drug. The important thing about bupivacaine is it keeps soft tissue analgesia up to 12 hours. Up to 12 hours. Absolutely, for post-surgical pain control, this is the drug. Now, interesting, I have never in my life, never met a pediatric dentist who uses bupivacaine. Of course, why on earth would you? What reason would there be for a pediatric dentist to give a 5 or 6 or 8 or 10-year-old child a drug that keeps them numb for 12 hours? There is none. Unless it's maybe your own child and you want to shut them up. I'm not sure. But, you know, there's no reason. So a pediatric dentist will have one of the drugs on the right-hand side of the screen. They'll have the short-acting drug. This is what the pediatric dentist needs. Now, the surgeon, whether it's endo, perio, pros, oral surgery, doesn't matter, you're going to have intermediate and long-acting because you need this for post-surgical pain control. The general dentist who does everything needs one drug from each group. And you select the appropriate anesthetic for use in that patient today based upon what the patient is having done. That's what you want to do, a selection of drugs, okay? Acetocaine is another long-acting drug. It is no longer available on the market in dentistry, so we're going to take that away. This is the armamentarium you have. You may not have every one of these drugs available in Guatemala, but you do have one drug from each of these 3 categories. Now, a problem potentially is the fact that drugs do. Dr. Malamed, I get a phone call from an email from a dentist or a phone call from a dentist. Dr. Malamed, a patient came into my office today, and I was doing tooth number 5. No, let's make it tooth number 7. Okay, lateral incisor? Okay, good. Short root, right? Infiltration, easy, no problem. I'm doing a very small procedure on tooth number 7. I gave an infiltration of lidocaine with adrenaline, and it only worked for 5 minutes. I gave it again, and it only lasted for 5 minutes. So then I gave the patient some Setonest with epinephrine, and it only lasted for 5 minutes. I gave him Marcaine, because Marcaine is long-acting. It lasted for 20 minutes. What's going on here? How come these drugs are working shorter than they should? Well, there's a lot of reasons for it, and here's one of the most important reasons. I already gave you the reason. 15% of people will under-respond to any drug. The 2-beer buzz needing 6 beers to get a 2-beer buzz. Okay? That's an example. 15% of your population getting a drug that should last an hour will get less. By the way, 15% will get more. And nobody ever complains about them, do you? No. It's the ones where the drug doesn't work the way it's supposed to. That's one factor. Another factor, by the way, is technique. All right, so it's a lateral incisor. There's no technique involved in getting a lateral incisor numb. But in the mandible is where you see the variation in technique, because anatomy is different. But you want to get that drug as close to the nerve as you possibly can. You can't see where you're going. You're guessing. Essentially, it's a guess. The anatomy of most people is the following, and you put the needle in over here, and it goes in a straight line. It doesn't. It goes in a straight line, and you push the drug in, and then you don't really do this, but you cross your fingers. I hope it works. I hope it works, because you can't see. Accuracy. Another one is the status of the tissue. This is the endodontic problem, isn't it? Tooth number 31, tooth number 30, mandibular molars. Okay, general dentists also do mandibular molars, but you know what? Once you get into your practice and your practice gets busy, you realize that, it's interesting. Young doctors, recent graduates, going into your own private practice, you need patience, right? You need patience. And the younger dentist treats anything and everything. As a young doctor, you will be taking out impacted third molars. You'll be doing molar endo. You'll be treating screaming children because you need patience. Now, as your practice evolves and grows and you get comfortable, you know what? If you hear that kid screaming in the parking lot, you're on the telephone referring him to the pediatric dentist. Bony impacted third molars, you know what? Those phone calls at 3 o'clock in the morning from patients in pain, I don't need this aggravation. And you refer them to the oral surgeon. Let them take care of it for you. Molar endo, I can never find all the canals. I perforate all the time. You know what? You send them out to the specialist. And what happens over your career is you begin to do what you like to do. And you refer out the things that you don't like to do. But molar endo has traditionally been the hardest when it comes to pain control. And I'm going to give you the answers because it used to be the hardest. It is still. If you want to see a scenario for a failure of local anesthesia, give me an infected mandibular molar. There's no other tooth in the mouth that is more difficult to get numb consistently. We do have answers now. We do have answers, but that's the problem right there. And the reason is this tooth has been hurting. And the local anesthetic, it blocks soft tissue. That patient comes in and they've been hurting. They're not hurting for a day. What's today's date? The 26th of April? Okay. They come in today, they've been hurting since January 1st. And you know, why didn't he come in on January 2nd? Because it didn't hurt that bad. In other words, he's scared of you. He's scared of dentists. Yeah? And in his mind, the little bit of pain in that tooth on January 2nd was not as bad as the pain that you're going to inflict on him doing the dental procedure. So the question then is, well, why are you here today? And the reason is simple. I haven't slept in 3 days. He was buying aspirin. He was buying whatever over-the-counter remedies you may have for toothaches here. We have things called Numzit. It's eugenol, and you put on the tooth. He's here today because he hasn't slept in 3 days. Great. Getting a patient numb who has been in pain for a long time, who hasn't slept in 3 days, if you go, boo, he's out of the office. He is interpreting as painful. That's a problem. You go in, you give him the injection, his lip gets numb, his tongue gets numb, the tooth stops hurting. Doctor, God bless you, you are a savior. Now you haven't touched the tooth yet. Because in a moment this guy is going to hate you. You block nerve conduction right now. But when you start to drill or put a forceps on that tooth and stimulate that nerve, that's when you realize, you know, on the videotape, the guy on the ceiling, that's where he'll be. That's where he'll be. And by the way, that is when medical emergencies happen. Sudden, unexpected pain, that's when the medical emergencies happen, when you hurt the patient. So another factor, we have individual variation, we have accuracy in injection, we have the status of the tissue, we have anatomical variation. Look around the room. Look at the faces we have here. They're all very nice. Some are nicer than others, but you know, Rodrigo, yeah. But you know, we have mandibles that have the normal flare. We have mandibles that flare like that. We have patients up here in the maxilla where infiltration works all the time. Why does infiltration work all the time? Because the bone is thin, right? The anesthetic diffuses in. Guess what? 15% of the population have bone that is thicker, and infiltration doesn't work. By the way, getting on a different subject now, there are people, you know, mandibular infiltration doesn't work. Why? The bone's too thick? Guess what? 15% of your population have thinner bone. And somebody will say to me, you have Articaine in this country, right? Okay. Dr. Malamed, I love Articaine. Whatever the name is, Septines, whatever the name is here, okay? I love Articaine. Why? Because I don't have to give mandibular blocks. I can take Articaine and infiltrate in a buccal fold like tooth number 30 or 31 and get pulpal anesthesia. Now, I don't know if I should say this the way I'm going to say it, so the translator may want to be careful. I will say to you, Toro Caca. I'm going to say to you, bullshit. It doesn't do it. But think about that. In 15% of people, it probably does, because they have bone there that is not as thick. Okay, anatomical variation. I already mentioned to you the block versus infiltration. I'll go back to that again. And here's another one that is fascinating. The time of day you give the injection has a significant bearing on the duration of anesthesia of that drug. It's called chronobiology. And I'm going to come back. I think I'm going to discuss this for just a moment. Now, let's go back to that bell-shaped curve. The bell-shaped curve, the normal distribution curve. There it is. It says that if I want to go out and I want to open up a shoe store, because academics doesn't pay very, very well. So I'm going to go out and make money selling shoes. Now, I'm going to sell women's shoes because I'm not going to sit down and smell men's feet. So I'm going to sell women's shoes. And I don't know, actually, I don't even know women's sizes, so I'm going to go to men's shoes. Okay? I'm going to use American feet size. I have a size 14 foot. Now, that's a big foot. Big foot. Okay. In my shoe store, and I'm catering to everybody, there's a bell-shaped curve for shoe size, for foot size. Not many people have size 14, 15, or 16, so I'm going to buy just a little bit of those, men. I'm not going to buy a lot of 3s and 4s for men. I'm going to buy a lot of 7s, 8s, and 9s. That's the bell-shaped curve for shoe size in men. That's what happens. Simple. When you go into a record store, nobody ever does that anymore because we download everything legally only. Aren't computers great? Oh, God, I love them. Legally, okay. You go into a store, and if you want to buy the #1 hit song in the country, there's like 100 of them right in front of you. You want to buy this album from this group you heard in a cafe, they may have one, right? They'll buy, if it's interesting, if people like it, they'll buy it. Okay? Bell-shaped curve. Very, very simple. So let's take lidocaine with adrenaline. Let's go back to local anesthetics. Lidocaine with adrenaline and 1 in 80 or 1 to 100,000 concentration. Very, very simply, if I injected 100 people and took a pulp tester, 70 of those people will have pulpal anesthesia lasting for just about 1 hour. And that's why we say to you the drug is 1 hour. Most people respond to this drug for 1 hour. 15% of your population on that drug will have anesthesia lasting for more than an hour. Nobody will ever complain about them. Come on, my dental students, the dental students in this room. You go to the clinic at 1 o'clock in the afternoon, you get a start. We have to get a start check. You can go ahead and start working. You go ahead and you give the patient the injection. Now, it's 1 o'clock, it's 1:15, you start the procedure. It's 2:15, you expect this drug to stop working. But in some people it doesn't, it just keeps working. And maybe it's now 3 o'clock, you've had an hour and a half of pulpal anesthesia, and it stops working. Students call me up. Dr. Malamed, I need your help in the clinic. I come down to the clinic, and I say, what's the problem? The patient's not numb anymore. Oh, when did you give the injection? 1 o'clock. What time is it now? 3:30. 2.5 hours. How long did it last? 2 hours and 15 minutes. The drug's supposed to last 1 hour. You got 2.5 hours out of it, and you're complaining about this? You see, in dental, look, let's be honest. In dental school, there is no drug that lasts long enough. There is none. I mean, if you think about it logically, again, I don't mean this seriously. Don't start doing this. Marcaine, bupivacaine, would be the ideal drug for dental school. Because nothing is done in an hour in dental school. Yes, you know what's done in an hour? Finding your instructor. Right? They disappear. They're outside, And I'm hoping it's only a cigarette. I'm not sure what it is, But it's the other 15%, the hypo-responders. They're the ones we get concerned about. Some of those 15% are only numb for 45 minutes. But you know what? In America, the average appointment's 44. So in other words, as a patient is saying to me, doctor, I'm beginning to feel it, you're just about done. But some patients are only 30 minutes, some are only 15, and some are even less. And you know what? That's the way they are. You can't do anything about that. Other factors, type of injection you give. It's not, it's very, very true for two drugs. In other words, if I take prilocaine, if I take mepivacaine, and give a block or an infiltration, there are significant differences in the duration of anesthesia. If I take lidocaine, if I take articaine, there's not much of a difference between a block and infiltration. Some of the drugs, these two drugs specifically, if I take prilocaine, seat nest, and give an infiltration, all you're going to expect is 5 or 10 minutes. If you take prilocaine and give it by nerve block, you are going to get anywhere from 40 minutes up to 1 hour. See, if you have a patient and you're working for about an hour, and whatever the reason, you do not want to give epinephrine, whatever the reason may be, and by the way, there are very few, if any, reasons to use plain drugs, but whatever, you don't want to use epinephrine. This is a good choice. If you give it by nerve block, not infiltration, by nerve block, it's good. The other one is mepivacaine plain, 3% mepivacaine. By infiltration, only 20 to 30 minutes. By nerve block, closer to 40 minutes. So you do have a couple of drugs out there on the market that can provide decent durations of anesthesia, pulpal anesthesia, without including a vasoconstrictor. You do have them out there. They do not provide the depth of anesthesia. The anesthesia is not as profound. Please, that's a very important consideration. You don't have, if you're doing a shallow procedure, okay, then these drugs are nice. If you're going to go in and do endo on a vital tooth, they may work, but they're likely not going to work that well. And if it doesn't work well, it simply means, ow. That's what it means. Okay? Time of day. I'm an anesthesiologist, and I put people asleep usually at 7 o'clock in the morning, 7:30 in the morning. And all of this research I'm going to show you was done back in the 1980s in Eastern Europe. It was published in journals that essentially were not read in Western Europe and the USA and North America, Central America. We didn't read it. But there was an article published last year, 2005, in the medical anesthesia journal. The journal is called Anesthesiology. And it was chronobiology. And it turns out that all anesthetics, not just local, but all anesthetics, the intravenous drugs I use, the gases I use, all of them, work differently in individuals at different times of day. One other thing that we learned, we call it urban legend, urban myth, where it's something that I'm trying to give you one that still is an urban myth. There are alligators in the New York City sewers. Legend has it that there are alligators in the New York City sewers, okay? That's an urban legend. Another one is that redheads are hard to get numb. Redheads are more resistant to anesthesia. That was something we've always heard. But you know what? That's true. They have done, now you have to be a real redhead. Okay, not dyed, real redhead. But it's true. I mean, they've now done double-blinded studies with redheaded people versus non-redheaded people. And in fact, local anesthetics, general anesthetics, they need more. They do need more. Redheaded people. That's one of those urban myths that have come true. Okay, let's take this. We're assuming when it comes to chronobiology that you sleep at night and you're awake during the day. A normal biological rhythm is occurring. And as we'll discuss this afternoon, under cardiac arrest, most cardiac arrests occur between the hours of 6 a.m. and noon. Most cardiac arrests occur when you wake up, when the alarm goes off. Wouldn't you call that an insult to your body? A jolt of adrenaline? Okay. Most cardiac arrests in the Western world occur between 6 a.m. and noon on Monday, the first day of the work week. You had this nice weekend. As bad as Tuesday is, Monday's worse, because Monday's the first day of the week. You have to go back to work. Things happen biologically. There are different levels of hormones and things in your body, depending upon the time of day. If you take people who sleep at night and are awake during the day, and if you take pulp testers and you test their teeth at 8 o'clock in the morning, at 11 o'clock in the morning, at 3 o'clock in the afternoon, and 6 o'clock at night, you will find that for the typical individual, remember there's a bell-shaped curve, for the typical person, teeth are most sensitive at 8 o'clock in the morning. 160% increase in sensitivity to the lowest. The lowest sensitivity is 3 o'clock in the afternoon. All right, now that's one study. This study, or these studies, are done individually with local anesthetics. Lidocaine, mepivacaine, articaine. Butoxycaine is a drug that is not really used by anybody, so I'm not going to mention it. But the point is, they brought patients in at 8 o'clock, 11 o'clock, 2 o'clock, and 5 o'clock, and they did dentistry. And they evaluated effectiveness of the anesthetic drugs. Same patient, same injection, inferior alveolar nerve block, same doctor. So the only variable was time of day. Same injection, same patient, same doctor, different time of day. And what they found with articaine, now this makes sense because the pulp test studies show that teeth are least sensitive at 3 o'clock in the afternoon, and teeth are most sensitive at 8 o'clock in the morning. Articaine had its greatest effect at about 2 o'clock in the afternoon, 37% more effective than at 8 o'clock in the morning. Lidocaine in 2 studies, most effective at 3 o'clock in the afternoon, 40% increase, 60% increase over 8 o'clock in the morning. Mepivacaine, 3 o'clock in the afternoon, 69% increase in effectiveness over 8 o'clock in the morning. Okay, what does it mean? Maybe nothing. You see, if John comes in the morning and you can inject him at 8 o'clock in the morning and he gets numb, it doesn't matter. But every doctor in this room who's in practice has a couple of patients, 3, 4, 5 patients, who they're just hard to get numb. I mean, every time they walk in that office, and I don't care what you're doing, you could simply be counting teeth. You say to your assistant, load up 3. They never get numb with 1. Never. You're doing the most simple thing in the world. You have to give them 2. You have to give them 3. In fact, you start with 3 automatically with this person. Why? I don't know. Bell-shaped curve. That's the way they are. You know what? If that person is coming into your office regularly at 8 o'clock or 9 o'clock in the morning, just try, if it's possible, to bring them in later in the day. The worst that'll happen is they're still hard to get numb. Try it. Now, conversely, if somebody comes in at 3 or 4 or 5 o'clock in the afternoon and is hard to get numb all the time, bring them in early in the day. There's just one more thing to consider when treating patients. When you have a patient who's hard to get numb, you might want to look at the time of day you give the injection. All right, so let's now go through the drugs, and then we'll take a break and get into technique. I'm going to go through the drugs individually with you very briefly to give you the clinical differences in these medications. Now, they're all marvelous drugs. They're safe. All these drugs are safe when used properly. And that really is the most important thing we're saying, is used properly. And that means you're going to inject slowly, you're going to aspirate before you give injections, all the stuff you were taught in dental school. And we'll come back to that after the break when we discuss technique. But we have lidocaine now. Again, I don't know what concentrations you have here of epinephrine, but in America we have 1 in 50,000 epinephrine, 1 to 100,000 epinephrine. Other countries have 1 in 80,000. Other countries have 1 in 300,000. Different concentrations. It doesn't matter. You have epinephrine, okay? And The onset of anesthesia. Now, I'm talking about giving an injection, taking a pulp tester, putting it on that tooth, and getting a maximum reading with no response. 80 over 80 on a pulp tester with no response from the patient. Profound pulpal anesthesia with this drug occurs within 3 to 5 minutes. 3 to 5 minutes. Now, here's something that I want you to keep in mind right now. It's a major dental meeting in America called the Chicago Midwinter Meeting. Now, you do not want to go to that meeting because it happens in February in Chicago. You're complaining to me it's cold out there this morning. This is not cold. Go to Chicago in February. When Fahrenheit it's -10. And it's windy. Guatemalans freeze. You don't want to go to Chicago in February. But at that meeting, very big, by the way, it is a very good meeting, and it's worth going to. Chicago is a very nice city to go to also, in case anybody is listening from Chicago. I'm just kidding. I want to go back to Chicago. Sometimes it works when you do that, you know. I see the light right there, you know. So they have what's called a lunch and learn. I have a table of 8 doctors, and they eat lunch, and we talk. We talk about whatever. And I once asked the doctors it was a local anesthetic discussion, and I asked the doctors, when you give a patient an injection of local, how long do you normally wait before you start to treat the patient? You give the injection and you wait. How long do you wait? And I was shocked. They were telling me 10 minutes. They were telling me 15 minutes. And you know what? That's way too long. Every drug that you're using today in dentistry will have an onset of anesthesia within 3 to 5 minutes. 3 to 5 minutes. And by the way, at 5 minutes, if that patient is not numb or just about numb, re-inject them. Okay, I mean, if your appointment is 1 hour, it's 1 hour. And if you're waiting 10 or 15 minutes to start, you're wasting precious time. Now, you understand in dental school, there's no such thing as precious time. You can wait an hour before you start in dental school. It doesn't make a damn bit of difference. But in private practice, isn't the term we use time is money? Okay, these drugs work within 3 to 5 minutes. Pulpal anesthesia for 1 hour. Soft tissue, 3 to 5 hours. Okay, this drug in this country, I understand, is the #1 most popular drug. That's what I was told by some of the students who know nothing. But I was told by some of the students who know everything. I know every McDonald's in Guatemala City. Been at let's go to the new McDonald's, the brand new one. But the point is, this is the drug that most doctors use. You know why? Because it meets the characteristics of what you do in your practice. Now, we have mepivacaine. We have mepivacaine 3% plain, 3% with no vasoconstrictor. Onset of anesthesia, 3 to 5 minutes. But since it doesn't contain epinephrine, it doesn't last that long. And this drug will last about 20 to 40 minutes. This is the drug that is very nice for a short procedure. For a short dental procedure, it's a very nice drug, 20 to 30 minutes maximum. Soft tissue anesthesia, 2 to 3 hours. This is the reason why the non-pediatric dentist likes this drug. They don't want the child to leave the office with their lip numb for 5 hours and little Mario or somebody chewing on his lip and get his lip coming back swollen. They don't want that. So they give them this drug, thinking, and it is a good drug when used properly. Remember, it is the most popular local anesthetic in children when the dentist who's doing the treatment is a general dentist. Take the same drug, add a vasoconstrictor. You may have it with epinephrine. We have it with a drug called levonorepinephrine. It's a synthetic epinephrine type drug. It's a 2% solution. Now, these numbers on the right-hand side of the screen are exactly the same numbers as lidocaine with epinephrine. There's no difference. Onset of anesthesia is 3 to 5 minutes. Duration of pulpal anesthesia is 1 hour. Soft tissue is 3 to 5 hours. You know what the difference is in these two drugs, lidocaine and mepivacaine? The difference in these two drugs is the difference between Coca-Cola and Pepsi-Cola, which essentially means they're the same. True? I mean, I like Pepsi better than Coke, but essentially they're the same. True? They're brown, they're sweet, and they're bubbly. Did you ever go into a restaurant and you wanted Pepsi-Cola and they said, we only have Coca-Cola? Did you leave the restaurant? No, I'll have Coke. They're the same. These are basically the same. They're different chemicals. They're like Pepsi and Coke, but they do the same thing. Rapid onset, 1 hour pulpal, 3 to 5 hours of soft tissue. Clinically, very little difference in these two medications. Prilocaine. Prilocaine is a 4% anesthetic. 4% in this situation with no vasoconstrictor, plain. Onset of anesthesia is 3 to 5 minutes. Now, this is the drug that has the tremendous difference in duration. If you give it by maxillary infiltration, only 5 or 10 minutes. If you give it by a nerve block, as in, again, inferior alveolar nerve block, you will get up 40 minutes up to an hour. Soft tissue will not be that long. It's only 2 to 3 hours, maybe a little bit longer, but only 2 to 3 hours. Prilocaine with a vasoconstrictor. Now, I'm not sure what you have here, whether it's epinephrine or felipressin, but the onset of anesthesia is 3 to 5 minutes, and look at the numbers. Just like lidocaine, just like mepivacaine, 1 hour pulp and 3 to 5 hours of soft tissue. So lidocaine is Pepsi-Cola, mepivacaine is Coca-Cola. I don't know what else you have here, but we have something called RC Cola. All right? Same thing, right? Same thing. You pick whichever one you like. They're all nice drugs. Articaine. Articaine is ginger ale. Is ginger ale the same as Pepsi and Coke? No, there's a difference. Articaine is 4%. 4% with epinephrine, either in a 1 in 100 or 1 in 200,000 concentration. This is the only anesthetic drug that works faster. 2 to 3 minute onset. There's no dental student who cares about that. Every dentist loves it for that reason. That's one of the reasons why most dentists like the drug. It's not the only reason. I like Articaine because, and it works faster. I don't have to wait 5 minutes. It works within 2 to 3 minutes. Okay, good. No problem with that. With epinephrine, 1 hour of pulp and 3 to 5 hours of soft tissue. Another drug that fits the 1 hour grouping perfectly. Very nice medication for 1 hour. Then we have the only other drug, and that is bupivacaine. Bupivacaine has only one brand name in the entire world, Marcaine. Marcaine. It is a very potent drug. In fact, it is so potent it's only used in a 0.5% concentration. 0.5% concentration. Not 2%, 3%, 4%. It's a 0.5% concentration. The onset of anesthesia of bupivacaine is slow. Very slow. 6 to 10 minutes. The only local anesthetic which is slower is the drug that your great-great-grandfather used to use, Novocaine, Procaine. Back in the 1920s, into the 1930s and early 1940s, before lidocaine was introduced, they used the ester-type anesthetics. We're now using the amides, right? All the drugs I just mentioned are called amide local anesthetics. They use the esters, Procaine, cocaine, tetracaine. We still do use benzocaine as a topical. Those are esters. Your great-great-great-great-grandfather went into his office here in Guatemala City back in 1920, and he took a pill of Procaine, a mortar and pestle, pulverized the pill, added some sterile water to it, put it into a porcelain thing, and heated it. He sterilized his own anesthetic. He then put it into a syringe, added some adrenaline, gave an injection. You made your own drug back in that day. Now, Procaine. inferior alveolar nerve block. 8 o'clock in the morning, open wide. Abre la boca. Adios, I'll see you in 10 minutes. Grandpa walked outside, read the El Diario. He smoked a little, whatever Grandpa did. You know, Grandpa was a little loco, yeah. But always happy, always happy. 10 to 15 minutes later, he walked back in, and maybe the patient was numb. That's how slow Procaine was, 10 to 15 minute onset of anesthesia. That's one of the reasons why in 1948, when lidocaine was introduced, the first amide, it worked in 3 to 5 minutes. Oh my God, they loved it. They loved it. Alcoholism dropped. Grandpa never read the newspaper anymore. He had no time. He had to go to work. It was good. It worked. So this drug is the slowest. The drugs you have today, this is the slowest. But you know what? The way this drug is used in dentistry, the slow onset doesn't really matter. You're not using this drug for the filling, for the crown. You're not doing that. You're using lidocaine, mepivocaine, prilocaine, articaine. Rapid onset, good duration. You're using this drug for later. This is used for when they leave the office. For when the lidocaine goes away, they still have anesthesia produced by this medication for 12 hours. This is primarily used for post-surgical pain control. Now, let me finish up with discussion of post-surgical pain control, then we'll take our break. Post-surgical pain control. It's not just post-endodontic, it's post-surgical. Whether it's an implant or perio, oral surgery, it's irrelevant, okay? What we're going to be doing, if you are doing surgery, and surgery in dentistry for most procedures is elective. So the patient is scheduled to come into the office at 9 o'clock in the morning, 11 o'clock, whatever they come in. If you are thinking in terms of the overall patient comfort during and following the procedure, you want your patient, when they come into the office, to have taken orally, before they come in, an anti-inflammatory dose of an NSAID, non-steroidal anti-inflammatory drug. Again, the drugs you have may be different. We have ibuprofen, we have naproxen. Those two are probably available everywhere. And there are many, many others. But non-steroidal anti-inflammatory drugs in the patient's bloodstream in a therapeutic level before you start the procedure, less damage is done to tissues. First thing, oral anti-inflammatory dose of the medication an hour before you do the surgery. Then when the patient arrives in the office, whatever local anesthetic you like, every doctor in this room has their favorite drug. Now, you know what a favorite drug in your hands is? It is the drug that you've had the most luck with. All these drugs work. They're all good anesthetics. If you find the nerve, they work. You know, Dr. Malamed, I got a bad batch of lidocaine. You didn't get a bad batch of anything. That lidocaine is fantastic. How do you, what's the problem? Well, you know what? Every time I give a mandibular injection with this drug, with this box, it doesn't work. And you think it's the drug? You know what? Before you write a nasty letter to the manufacturer of the drug, take that bad batch of lidocaine and give a couple of maxillary injections and call me back. Dr. Malamed, it works in the maxilla. Do you think there's an anesthetic drug that is so, I don't know what even the word is, that it works differently in the mandible and maxilla? That's nonsense. We'll discuss mandibular anesthesia after the break. You know what? Don't blame the drug. That same drug that doesn't work on number 31 works on number 4. Uh-oh, well, does it mean that my technique is bad? Yeah, it could be. Don't blame yourself. Dentists commit suicide. We don't need any aggravation. No. Blame the patient. Blame them. They're wired wrong. Your nerves are in the wrong spot. I'll discuss that after the break, okay? But you take your local anesthetic, you give the injection, whatever drug you like the most. Now, at the end of your surgery, at the end of the surgery, now I'm assuming the surgery is going to go for about an hour or longer. At the end of the surgery, before you dismiss the patient, maybe the last thing you do in their mouth is you re-anesthetize them with bupivacaine. Now, see, if you're doing a short procedure, you're in and out in 15 or 20 minutes. Give your first drug and bupivacaine one after the other. But if you're doing an hour or longer, save the bupivacaine for the end, because you want that drug to work for the rest of the day. Okay? Now, next to the last thing. You cannot guarantee, nobody can guarantee 12 hours out of that drug. Remember the bell-shaped curve? Some patients may only get 3 hours. You can't guarantee it. So if you want your patient, when the bupivacaine effect finally goes away at 9 o'clock at night, if they have in their bloodstream at that time a non-steroidal anti-inflammatory drug, naproxen, ibuprofen, you have Toradol here, ketorolac, which I saw out there, injectable out there, I saw it yesterday. If they have in their bloodstream, when the anesthetic goes away at 9 o'clock at night, if they have a therapeutic blood level of ibuprofen, naproxen, ketorolac, ketorolac, there's no pain. And that is the best way to manage postoperative pain. You give the patient the preoperative dose, whatever local anesthetic you like for the surgery, bupivacaine at the very end of the procedure, and you have your patient continue to take their non-steroidal anti-inflammatory drug every X number of hours. Some drugs are every 6 hours, some are every 8, some are every 12. Whatever that drug is, keep a therapeutic blood level of that non-steroidal drug, and when the local anesthetic effect goes away, there's no problem. And they love you for it. One last thing. And I know you do this. I hope you do this. It's the best thing that you can do to make patients love you, if you care about being loved. In America, by the way, it means not being sued. Think about this. Being loved means not being sued. Right? If something goes wrong, whatever it is, if something goes wrong and that person likes you, they're less likely to go to court and sue you. Now, if that person doesn't like you for whatever reason, they're going to sue. Now, when you make that telephone call that evening, you did surgery, whatever you did. Hello, this is Dr. Malamed. Just want to check up and see how you're feeling. First thing is, this patient can't believe that a doctor would call me. Wow. From that point on, you can do nothing wrong. Number one, you can pick up on minor postoperative problems early in the evening. Remember I told you earlier I don't like phone calls 3 o'clock in the morning? Well, you know what? If I have a problem at 7 o'clock at night, a minor problem, I'll meet you down at my surgery in a half an hour. We'll take care of the minor problem before it becomes a big problem later on. You can go back over the postoperative instructions one more time. Remind your patient to keep on taking their non-steroidal anti-inflammatory drug. This regimen works nicely. Now, let me finish up the morning by going, this chart, hard to read, but a study done by Carl Kaiser, and it was on effectiveness of analgesic drugs, oral analgesic drugs, and things like codeine, morphine, codeine, acetaminophen and codeine do not work well. You do not need codeine. You don't need narcotics for post-surgical pain control. What worked best was ibuprofen, 800 milligrams of ibuprofen. The anti-inflammatory analgesic dose of the drug, 800 milligrams, worked the best. Non-steroidals are excellent, excellent medications when it comes to pain control. I have something I want to show you before we take our break. It's a television commercial. In America, our television is boring. And in fact, we have this device called TiVo. TiVo, a DVR, allows you to record television shows when you're not watching them, and then you can come back and fast forward through the commercials. Okay, So the average 1-hour television show is only 42 minutes without commercials, which is fantastic. Our commercials are terrible. That's why we go through them. I collect commercials from other countries where they are more interesting. This is one example of it right here. Okay, it is break time. See you in a half an hour. All right, welcome back. This is my email address. If anybody has any reason to email me, if you want to send me a message, send me money. Any questions about anesthesia, any questions about medical emergencies, anything, just feel free to email me. I do communicate rather well by email, so don't be Stanley at drmalamed.com. Now, I also have a website, and you might be interested in some of the things I have on that website, because this afternoon on medical emergencies, I will be discussing, obviously, medical emergencies. I have on the website some downloadable material. I'll be talking this afternoon, for example, about the new guidelines for CPR. And if anybody wants to get a copy of them, I have them available on my website, and you can download it. So the website is drmalamed.com. And again, I'll talk about this afternoon. I'll show you exactly what I'll be discussing this afternoon. So you can email me, you can go to the website, you can do whatever you want, but there it is. Now, what I want to do between now and 12:30 is discuss techniques. So far, we've discussed the local anesthetic drugs. They work. If you deposit the drug near enough to the nerve and the drug diffuses into the nerve, you're going to get anesthesia. So now we have to discuss a little bit of the anatomy and how to get, what these injections do for us. I'm going to start out by discussing the maxillary arch. Now, we don't normally need to discuss this in any detail, because what most doctors do, and I don't think this is the appropriate thing for you to do, but what most doctors do once they graduate from dental school is they do maxillary infiltration. If you're going to work on tooth number 3, number 8, number 12, number 15, you give an infiltration, and it gets that one tooth numb, and that's perfectly okay. There is no problem with an infiltration if you're working on one tooth. The problem is that very often in private practice, you work on quadrants. You work on an area. You're doing crown and bridge on 4 teeth. You're doing periodontal surgery in an area. And nerve block anesthesia does so much more for you. It gives you, 1 injection versus 5. 5 infiltrations, one of these nerve blocks gives you the same degree of anesthesia as 5 of the infiltration injections. The problem is that dentists simply, for some reason, they're resistant to doing these maxillary injections. So what I want to do is, I don't want to convince you and make you, start doing nerve blocks. I want to show you what's out there, what's available. And maybe, see, by the way, where are the dental students? I want to see hands. I want to see the hands of all the people who are dental students, currently in dental school. Do not be afraid. I will not pick on you. I want to check. Now, keep your hand up. I want to see what I'm dealing with. The future of dentistry. The future looks pretty good. Let me start out with some very basic stuff. And as I go along, I have to make certain assumptions. And the assumptions are going to be that you give injections. Whether you are a 4th-year student, 5th-year student, 8th-year student. See, USC School of Dentistry is only 4 years. We have some 5- and 6-year students. That's just the way it happens, right? You give injections. So there are certain obvious things we have to take for granted, like you know what needle to use and you know how much anesthetic to put in. Well, I take nothing for granted because I know that you do not know what needle to use and you do not know how much anesthetic to put in. These are the things that every dentist does wrong. So and what I'm saying is that doing it wrong is not bad. It's not right. But if you're using the wrong gauge needle, needles are in America 25 gauge, 27 gauge, and 30 gauge. You know, I would say to you, there is no justification at all ever for use of a 30 gauge needle in dentistry. None. You shouldn't be using them. And yet, the most popular needle in American dentistry, 30 gauge. Okay? So you do what you want to do. But there's no reason that I would say to you they're dangerous, but I'll get into that later on. The American dental cartridge holds 1.8 mLs of fluid. And the average American dentist, no matter what injection they're giving, gives 1.8. You don't need 1.8. You don't need it. We do it. Why? Because it's there. I can't use it again. Well, I'll give Maria 1.3 and give Juan 0.5. No, you can't do that. So they just give the whole thing. Is it dangerous? No. Until you start treating children. And then giving 1.8 as a routine becomes dangerous. So I'm going to go through the numbers with you. I'm going to go through the basic injection right here. I'm going to go through some of the nerve blocks in the maxilla. We'll spend most of the rest of the morning session discussing the mandible, because if you haven't had it yet, you are going to. It's called a mandibular slump. It's when nothing works. You try every drug, you try every trick you have, and you can't get the patient numb. Not in the maxilla. Maxilla is fine. Mandible. And every dentist is going to go through this. So we'll talk about mandibular anesthesia primarily this morning. Infiltration, also known as a supraperiosteal injection, is indicated when you're treating one tooth. It's a beautiful injection for one tooth. And that's why in dental school we do a lot of this. Because most of the time in restorative dentistry, which is the biggest clinic in most dental schools, okay, you work on one tooth. In fact, you work on one tooth for 2 visits, for 3 visits, at least in the United States. You know, nothing ever works well. So we're going to use a 27 gauge short needle. Let's go back to needles, okay? I said forget about 30 gauge needles. So what do we have? We have 25 gauge and 27. 25 gauge, of course, is thicker, and 27 is thinner, and 30 is even thinner. We have 25 and 27, and we have long and short. Now, the average long dental needle, depends upon what company you buy it from, but the average long needle measures 32 millimeters in length. 32 millimeters. An inch is about 25 millimeters. So the average long dental needle is about 1.25 inches. The average short dental needle is 20 millimeters, a little bit less than 1 inch. So I'm going to say to you that my ideal armamentarium for needles, what I teach my students to use. Now, in school they have to do it, but then you graduate and you do what you want to do. My ideal armamentarium is to have one long needle and one short needle. Long needle will be 25. I like 25 gauge needles. 25 gauge long, 27 gauge short. Now, when do you use which needle? You pick a needle for use in an injection based upon how far in you have to go. In other words, you're going to penetrate soft tissue and go in until you get to where the nerve is. Now, in some cases, the end point may be when you go in on an inferior alveolar nerve block, as we'll discuss later, you go into your contact bone. There is a defined end point in that injection. You go to your contact bone. Okay, the average adult from the puncture point down to bone, which is the lingual aspect of the mandibular ramus, 20 to 25 millimeters. Now remember, a short needle is 20 millimeters long, and a long needle is 32. Now you mentioned Leonard Mannheim's name. By the way, I thank you very much for putting me in the same category as Leonard Mannheim. I mean, that's an honor. Going back to the 1940s when Dr. Mannheim wrote the book on local anesthesia, there's a statement that's always in the book. It's in my book because I simply copied his book. That's what I did. Yeah. It's called plagiarism, but you know. Never insert a needle all the way into tissue to the hub. Never insert the needle its entire length into the soft tissue. Never. And the reason is simple. I get involved because of what I do. I teach local anesthesia. I get involved with the legal problems. And one of the legal problems, which is not the worst legal problem, because the worst legal problem is a dead patient. You understand? That's worse. Okay? What we're dealing with here is a broken needle. The needle broke off in the patient's mouth, and the needle is still there. Now, I've been teaching since 1973, so that's 33 years. I have been involved with 61 cases. That's not a lot. In the United States of America, every year in dentistry, the manufacturers of local anesthetics sell 300 million cartridges. 300 million. Now, assuming that there are doctors who give more than one injection per cartridge, that means that we are, let's put it bluntly, we're sticking needles in that patient's mouth probably 500 million times a year. Okay, it's a lot. Multiply that by 33 years. I've been involved with 61 cases in almost 2 cases a year, period. So the odds are that you will never, ever in your career, ever have a needle break. It's rare. Now, when they break, 61 broken needle cases, 61 in the mandible, 61 inferior alveolar nerve blocks. Okay, now, why? All 61, the doctor was using a short dental needle. In other words, they went in all the way to the hub, the entire length of the needle. In 60 of the 61 broken needle cases, it was a 30-gauge needle, the thinnest needle. In 60 of the 61 broken needle cases I've been involved with, it was a 30-gauge short needle. The only other one was a 27-gauge short. I think all the evidence is right there. If 60 of 61 broken needles were 30 gauge and the 30 gauge is the thinnest little needle, don't you understand it's more fragile? It can break more easily. So I'm going to talk about needles today, 25 long. I'm going to use the long needle if I'm going in close to 20 millimeters or more. I'm going to use a short dental needle for anything else. So on this injection, I need a short needle. On a maxillary infiltration, I need a short needle. Because you're not going to go in very far. You're going in from your puncture point until your needle tip is at or above the apex of the tooth you're treating. So if you imagine the buccal fold and you're doing a central incisor, you're going to go in 10 millimeters maybe. You're doing a lateral incisor, you're barely going to go in because it's a very, very short root. You're doing a canine, you're going to go in a lot further because it's got a long root. First and second premolars, the molars, short roots. That's why you don't miss. In fact, the tooth that is most often missed is the canine because the doctor didn't go in far enough. Okay? How much anesthetic? You're going to put in 1/3 of a cartridge. That's it. 1/3 of a cartridge. You don't need a lot. Oh, I'll put in 1.8. Okay, fine. Put in 1.8. Doesn't do a darn thing for you. It's not really dangerous, but you don't need it. You don't need to put that much anesthetic in. I will be showing you, I'll discuss this, then I'll show you a video. The video is part of the DVD. If you are smart enough and you buy my book and it comes with a DVD, this is the DVD you're going to see. I've taken parts of it to show you. Maxillary infiltration is used to achieve pulpal anesthesia of 1 or 2 maxillary teeth. The area anesthetized is the pulp and the buccal soft tissue and bone of the tooth anesthetized. The recommended needle is a 27 gauge short. The insertion site is in the height of the mucobuccal fold over the apex of the anesthetized tooth. The needle is held parallel to the maxillary bone and inserted until the needle tip is at or above the apex of the tooth. After 2 negative aspirations, 1/3 of a cartridge of local anesthetic is slowly injected. Okay, simple injection, 1/3 of a cartridge. Remember, the drug works usually within 3 to 5 minutes. Go to work, you got it. Very, very simple, your basic injection. Now, the problem we have is that there may be an occasion when it doesn't work. Now, I already mentioned one, the tooth has got a very long root. Okay, that's one reason. Now, the other reason is infection. The other reason could be, by the way, bone. The 15% of your population in the maxilla whose bone is thicker than it should be. But other reasons are things such as a patient who comes in for endo. I mentioned it in the mandible this morning. The same thing is true here. When you have a tooth that is infected, you have hyperemia, you have inflammation, it's just difficult to get this tooth numb. Depositing local anesthetic in the area of infection, the drug simply doesn't work well. That's why doing the nerve block injection, the ASA, the PSA, and others, you're putting the drug in an area away from the infection and the anesthetic works better. That's an indication for doing nerve block anesthesia. So the first of the injections I want to mention in the maxilla is called the posterior superior alveolar nerve block. And we abbreviate that with the initials PSA. This will provide pulpal anesthesia to all 3 maxillary molars. Now, by the way, maxillary molars on occasion are missed by infiltration. And the reason is the palatal root. If the palatal root is in its normal configuration, when you infiltrate in the buccal fold, the anesthetic will diffuse from here to here, this distance. And the root, all 3 roots are in that area, so you have no problem. But some people have palatal roots that flare way toward the midline. You don't know that. And if you give lidocaine, mepivacaine, or prilocaine by maxillary infiltration, and the patient has one of those palatal roots that flares toward the midline, you ain't going to get it. A nerve block will. Nerve block anesthesia will. And the PSA is a very simple injection. You're going to use a short needle. Remember, 20 millimeters in length. You're going to use a short dental needle. And you'll see this on the video in just a moment, exactly how it's done. All you need is a half a cartridge of anesthetic solution. You don't need a lot. It's a very simple injection. The patient doesn't feel this injection. This is an injection in which you do not touch bone. By the way, you do not touch bone either in the infiltration. You don't touch bone. And not touching bone means it doesn't hurt. On a PSA, you do not touch bone. It doesn't hurt. Again, what this does for you is anesthesia of the 3 maxillary molars. The posterior superior alveolar nerve block provides pulpal anesthesia to the 3 maxillary molars and the supporting buccal soft tissue and bone. In 28% of patients, the mesial buccal root of the first molar may not be anesthetized. A 27-gauge short needle is recommended. For the left PSA nerve block, a right-handed operator should sit at the 10 o'clock position facing the patient. For the right PSA nerve block, a right-handed operator should sit at the 8 o'clock position facing the patient. The insertion site is the height of the buccal fold adjacent to the maxillary second molar. The syringe is held in an upwards, inwards, and backwards direction and is inserted to a depth of 16 millimeters. After 2 negative aspirations, a half a cartridge of local anesthetic is administered over 30 seconds. Very, very simple injection. You're going to see the same doctor and same patient on all these tapes. The young lady up there is my dentist, and she gives marvelous injections because she had a good teacher. Okay. And when think about something. Can you imagine? I think you use my book, maybe, hopefully. Okay. If I were in your chair and you're giving me an injection, you'd be a little nervous. Yeah, but some people would be nervous because he wrote the book on local anesthesia. So she's my doctor, and she's always a little bit nervous I'm in the chair. The young man in the chair was a dental student at that time. He's since graduated. It took us 2 days to film this DVD, 2 days. He received 80 injections in 2 days. Now, we didn't inject local, but we did do the injection. You got 80 injections. Now, if you watch carefully a little bit later on, and again, I think the lights need to be on here, right? If you watch carefully when we're giving some of these injections, look at the areas, other areas in his mouth. You'll see red things. That's where he got the other 79 injections. You can also tell what time of day it was. We started shooting at 6 o'clock in the morning, and we finished at 1 o'clock the next morning for 2 consecutive days. Some of the video, he's clean-shaven. In other parts of the video, you see the beard. So you can tell when the movie was shot. PSA gives you the 3 maxillary molars. Now, the other injection I want you to consider doing, and it's a very simple injection, is called the anterior superior alveolar nerve block, the ASA. Some people might incorrectly call this the infraorbital. Okay, again, I'm a teacher. Okay, this is one of those trick questions in dental school. See, I will say to you right now that every one of you in this room has given an infraorbital nerve block. Every one of you did. You don't know you did it. You didn't mean to do it, but you did. You have not done the ASA, you've done the infraorbital. You are giving an infiltration over a canine, maxillary canine. Long route, so you go in a little bit further, and you deposit your anesthetic drug, and the patient, as they begin to get numb, says to you, I can't close my eye. Right? They say to you, my nose is numb. Okay? That's the infraorbital nerve. The infraorbital nerve comes out of this hole right below your eye, the infraorbital foramen, and it innervates sensory anesthesia to the lower eyelid, the side of the nose, and the upper lip. A totally useless nerve unless you're doing a biopsy of the lip. It's, there's no reason for it in dentistry. So the infraorbital nerve is of no importance to you. That's why you're not going to call this the infraorbital nerve block. Infraorbital nerve does not give anything. There's no pulpal anesthesia. The nerve that goes to the 5 maxillary anterior teeth is the nerve that is inside that hole. And inside that hole, the infraorbital foramen, inside that hole is the anterior superior alveolar nerve. Okay? So what you're going to do is very, very simply infiltrate local anesthetic outside the infraorbital foramen. So look, this fingertip of mine is the canine. This is the apex of the canine. Above it, over here, is the infraorbital foramen. So instead of doing an infiltration and simply stopping my needle at the apex of the canine, I'm going to go further. I'm going to stop my needle outside the infraorbital foramen. But wait, Dr. Malamed, I got a problem with that. Because as you keep on going up and up and up, what if you go too far? The eyeball. I mean, I can see going up and going up and going up and then hearing this. And then this viscous material just oozes out. Yeah, that can't happen. Can't happen. Reason it can't happen is bone. If you put your finger on your infraorbital foramen or your next door neighbor's infraorbital foramen, and you're not even close, lady. Okay, sit up straight. Sit up straight. Now, go ahead. A little bit, come down. Right there, push hard. Does it hurt? That's it, okay? She's poking in her eye. The infraorbital foramen. Now, if you put your finger on the infraorbital foramen, it should feel sore because you're pressing the infraorbital nerve against bone. If you press in and then slide your finger up towards your eye, there's a ledge of bone. There's a piece of bone that protects your eye from the needle. So on this injection, you're going to insert your needle over any tooth. Doesn't matter. The canine, the first premolar, the second premolar. It doesn't matter. So you're aiming for this hole over here. If you insert your needle by the central incisor, then this is your angle. If you insert by the lateral incisor, by the canine, by the first premolar. If your end point is here, it doesn't matter how you get there. You know how physicians get there? Easy. So easy. They just come in this way. Now, in America, a dentist is legally permitted to give extraoral anesthesia. I could legally do this in dentistry. Most dentists, no, not most, all dentists don't do it. Dentists have this problem with putting needles in skin. Mucous membrane, we love. Put needles in mucous membrane every day. I teach IV sedation. I teach venipuncture. You know what? About 10% of my students, when they do, not the one getting, the one doing the venipuncture, faints. Injections in the mouth, dentists have no problem with it. Once you get on the skin, we have a problem. But this injection, all you need to do is deposit the anesthetic outside the infraorbital foramen. And again, what's safe about the injection is you go until you contact bone. The bone is the roof of the foramen. Your needle is touching the roof when you deposit the anesthetic. If you do this injection, you will actually feel, as you deposit the drug slowly, you will feel a little lump. You will feel the anesthetic under your finger. Now, the patient says to you immediately, wow, my eye is numb, my nose is numb, my lip is numb. Yes, that's the infraorbital nerve. Take out the syringe. You're not done. The most important part of what we are doing in this injection, because see, the drug, we have to get the drug into the hole, into the infraorbital foramen. The drug is not going to do it all by itself. It needs help from you. So after you finish doing the injection, you put the anesthetic in, you put a half a cartridge in, you put your syringe down, and now the important part of the injection. You put your finger on it and you push. You help the drug go into the hole. By the way, if you don't push, it's not going to work well. You know why? If you don't push, the drug will diffuse everywhere. The cheek will get numb, everything will get numb, but not into the mouth. You got to put your finger on it, you got to push. Now, how long do you push? Minimum 1 minute. Maybe even 2 minutes. And you're a dental student, you can push for an hour. It doesn't make a damn bit of difference. But you know what? I'm an important person. I can't sit there for 2 minutes and push. I got important things to do, you know? I got things to do. I'm talking about cigarettes, not the other stuff. Do not do drugs. Now, so rather than me do this because I'm so important and so busy, I say to my patient, Maria, give me a finger. Takes the finger, Maria, push. Adios. I walk out of the room. Let the patient do it. But the important thing is you got to push. If you don't push, it's not going to work. Anterior superior alveolar nerve block, also known as the infraorbital nerve block, provides pulpal anesthesia to the 5 maxillary anterior teeth, the incisors, the canine, and the 2 premolars, in addition to the buccal soft tissue and bone overlying these teeth. The skin of the lower eyelid, the lateral side of the nose, and the upper lip is also anesthetized. For a right or left ASA nerve block, the right-handed operator should sit at the 10 o'clock position, facing in the same direction as the patient. The infraorbital foramen is palpated, and the lip is retracted. A 25-gauge long needle is inserted into the height of the buccal fold adjacent to the maxillary first premolar. The needle is held parallel to the maxillary bone and inserted until bone is contacted at the roof of the infraorbital foramen. After 2 negative aspirations, 1/2 to 2/3 of a cartridge of local anesthetic is deposited over 30 to 40 seconds. Okay, now, this is a new injection. Some of you may be doing the PSA, you may be doing the ASA. This injection was actually, invented in the late 1990s. And we call this the anterior middle superior alveolar nerve block, the AMSA. What does it do for you? Well, what the AMSA does is it gives you anesthesia of the 5 maxillary anterior teeth. It gives you anesthesia of the same 5 teeth that I just talked about. The incisor, the canine, the incisors, canine, and 2 premolars, the 5 maxillary anterior teeth. It gives you anesthesia of the supporting buccal soft tissue and bone over those 5 teeth, and it gives you anesthesia on the hard palate from the central incisors back to the third molar. Now, it's one injection that gives you both teeth, buccal soft tissue, palatal soft tissue, and bone. It does not give any anesthesia extraorally. In other words, the infraorbital nerve is not anesthetized. Patients love it. The lip is not numb, the nose is not numb, the eyelid is not numb, their teeth are numb, their palate is numb. Now, the only negative that you may see in this injection is you give it on the palate. And dentists worldwide have a problem with palatal anesthesia because well, let's be honest, we know that the palate is more sensitive and that palatal injections can be more painful. Now, that's a problem. Okay, I was taught in dental school many years ago that palatal injections hurt. And therefore, I was taught in 1967, 1968, that before you give a patient a palatal injection, you should tell them you might feel it. And you know what happened? They felt it. And you know what I did? It was like, hey, it's not my fault. Right? It's not my fault. It's the palate. Well, I went to USC in 1973, and we have a department called Human Behavior. It's psychology applied to dentistry. And the chairman of the department, the founder of the department, was Dr. Nathan Friedman. He is a dentist and a psychologist. He's Yoda. He looked like Yoda. A wise man, bald, big ears. He wore a robe. He levitated off the ground. He was Yoda. And I was in the clinic one day helping a dental student. I was giving a palatal injection for the student. And I did my thing. I gave the injection. And I didn't know that Dr. Friedman was hovering around. And he called me over. And he went like this. You know, he's short, but he came up. Yeah, he couldn't sit. Yes, Yoda. He said, Dr. Malamed, I was watching you give this injection, and I want to ask you a question. Why did you say that to the patient? And I looked at him and I said, what do you mean? What did I say? You see, here's the problem. If you are in the habit of saying something all the time, you do it automatically. You don't even think about it. And if you've been in practice for a long time, if your dental assistant were here, your dental assistant would know exactly every word you say because you say the same thing to every patient you see. And you're not even aware of it anymore. So what did I say, Dr. Friedman? He said, well, you told the patient that they were going to feel it. And I said, but Dr. Friedman, it was a palatal injection. They felt it. And he said to me, here's where he lost me. He said, have you ever heard of a self-fulfilling prophecy? And I went, no. He's from Beverly Hills. I'm from the Bronx, New York. You know, he's highfalutin. I'm down here, you know. It means that if you think something is going to be painful, you will do it in a way which proves it is. So I said, okay. Then he said something that scared me. He said, get in the chair. Let me show you. Well, in all honesty, Dr. Friedman gave me a nasopalatine injection that I did not feel. I swear to you, I did not feel it. Is it magic? No. It's trying. And ever since then, 1973, in my books, I talk about what is called an atraumatic palatal injection technique. Now, I'm not guaranteeing, because nobody can guarantee, that all palatal injections don't hurt. You cannot guarantee that. But what I can guarantee is if you believe you can do it better, you will try. You will use topical, you will do whatever else you want to do. I take a cotton swab and I push against the palate, pressure anesthesia. And I maintain that pressure anesthesia as I slowly insert my needle, injecting local anesthetic as I go through. I try, I do everything I can. See, now look, I'm in a teaching institution, I'm not in private practice. In private practice, I would never do what I do in school. I finish giving an injection, then I say to the patient, how was that? In private practice, you don't want to know. You know, you watch the patient, right? Ah! You don't want to ask. You know, you don't want to ask. But in school I do, because it's a learning experience. Now, what I have found was that even though I try as hard as I can to make it not hurt, you can't guarantee it. And when we test pain, we do research on pain, and pain is very, very hard to do research on because it's very, very subjective. There's a lot of mental interpretation in pain. We use what is called a visual analog scale, abbreviated as VAS. And what it is a 10-centimeter horizontal line broken up into 1 centimeter. There's a little mark every 1 centimeter. So 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Under the 0, it says, I felt nothing. Under the 10, it says, the worst pain ever. And then you go ahead and you do whatever you're testing, you do it. And you ask the patient to make a little mark on that line to indicate what they felt. If you felt nothing, it's a 0. If you felt it a little bit, it may be a 1, it may be 1.5, maybe 2. The worst pain you ever had, 10. Now, I have had patients, honestly, on a nasopalatine, where the number 10 is the highest number. Some wise guy took that pencil and went like that and said 20. Okay? But you know what? With all the stuff I talk about, topical and pressure and injecting slowly, I can't guarantee you 0. But you know what I can guarantee? Even if it's a 4 or 5, I can guarantee the following. Mrs. Jones, how was that? Well, doctor, I felt it, but it was better than it ever was before. Now, remember back to that slide early this morning. What sells me as a doctor to that patient? Giving better injections. And if my injections, which are usually on the palate very painful, if mine are better in the eyes of that patient, this is a better dentist. Got it? This injection is given on the palate. This injection doesn't just give you palate, it gives you teeth and palate. If you're doing periodontal procedures, this is a marvelous injection. You're doing crown and bridge, you're doing surgery. Why give buccal and palatal? Why not give one injection on the palate? And it's a simple, simple injection to do. You have to put a lot of anesthetic in. You have to put in 3/4 of a cartridge. This is not right, by the way. 0.9 is only a half a cartridge. You have to put in 3/4 of a cartridge, which means something. It means you do it slowly, because you know you cannot inject on the palate. You can't do that. What you're doing on the palate is I'm right-handed, by the way, so doing lefty would be dangerous. You're sitting there. Now, I'm wearing a mask when I'm doing this. Now, I'm not nervous. I don't have a neuropathy. It's the tissue, isn't it? The palatal tissue is so dense. And by the way, you know what? It doesn't hurt my patient at all, but it's already hurting me. It's hurting me right there. I'm biting my lip. And by the way, my hand is tired. This injection was designed by Dr. Mark Friedman and Dr. Mark Hochman. In the 1990s, they were doing research with a new device, at that time was called the WAND. It's a computer-controlled local anesthetic delivery system. All you do is, and this is what the handpiece, this is what the syringe looks like. It looks like a saliva ejector on which you put a needle. Very non-threatening to your patient. It's become popular in the United States. I would say maybe 15 or 20% of the doctors have it. And the ones who have it love it. But you know what I would say to you, and by the way, the reason it's popular is it makes any injection painless, including palate. Now, how do we know? They did research with this device in the 1990s to demonstrate that this thing works in the palate. And they took that needle 27 gauge short, and they were, let's be honest, literally sticking it in and putting in anesthesia. And then asking patients, how was it compared to the regular syringe? And they found that anywhere they put this on the palate, it was better. It didn't hurt as much. But to their surprise, they found that if they put more anesthetic in than normal, in a certain spot, they got the teeth. And they called this the AMSA injection. So it's easy. I mean, it's really, really simple. What you're going to do is you take the premolars, and again, assuming there are two premolars, you take the papilla between the two premolars, and you draw this imaginary line right down to the midline of the palate. That's the landmark, from the papilla to the midline. And then you take your 27 gauge short needle and half the distance from the papilla to the midline, you put your needle in. Now, there's the injection site. You know what? If you strip away that tissue, and that tissue, by the way, is tenacious, right? It's firmly adherent to bone. The palatal bone is not solid bone. It has many, many little holes, little fenestrations, little foramina. It's a sieve. So when you start to deposit your local anesthetic, slowly, the soft tissue that is firmly adherent to the bone is pushing the drug into the bone. You're putting in 2/3 of a cartridge in this spot. You understand, of course, why the palate gets numb, because you're putting the drug in that spot. The question is, why do the teeth get numb? So let's go to this next picture. This is what I showed you a moment ago. This picture is of the same area from the buccal. So this is the area on the palate where you're putting the drug. As the drug diffuses into the bone here, what do you find? The ASA nerve. You're getting the ASA nerve from the palatal aspect. That's why the 5 teeth get numb. That's why the buccal soft tissue and bone overlying the 5 teeth get numb. And the reason the face doesn't get numb, because that's the infraorbital nerve, is the infraorbital nerve is way up over there. It's far away. It's nowhere close to where the anesthetic is being put. Fantastic injection. Periodontists, implantologists, surgeons, endodontists, anybody. It's a great injection. Okay? Called the AMSA. The anterior middle superior alveolar nerve block provides pulpal anesthesia to the 5 maxillary anterior teeth, the incisors, canine, and premolars, the buccal soft tissue and bone, and the palatal soft tissue and bone overlying these same teeth. A 27 gauge short needle is recommended. For the AMSA nerve block, sit at the 9 or 10 o'clock position, facing in the same direction as the patient. The needle is inserted into the tissues at a point halfway along the line between the premolars and the midline of the palate. 1.4 to 1.8 mLs of anesthetic is slowly deposited. That's it. Very easy injection to do. So that was the maxilla. Maxilla, you know, you can do your infiltrations, no problem with that. But nerve blocks, it's worth learning them because of the problems you might have on an individual patient. And if you have the PSA, if you have the ASA, if you know the AMSA, you can overcome these problems with no difficulty in your office. Commercial time. Okay, I didn't say they're all good. Mandible. This is probably 25 years of experience, me, at my university. I'm not always there, obviously, because I'm here today, and this is Wednesday and school is on today. But when I'm in the school, you know, the clinics begin at 9 o'clock in the morning, they begin at 1 o'clock in the afternoon, and on 3 days a week we have evening clinics. The student starts to get an okay from their instructor. I'm in my office, and I'm doing whatever tenured faculty do, which is I sleep. That's why there's no tenure here. You know, I'm doing whatever I do. and the student gives an injection, and it almost always works. But they miss, whatever it is, they miss. And they give a second one, and they miss. Our suggestion is if you miss two, call over a real dentist. Call over your faculty. And the faculty is very much perhaps like you have. We have dentists we have some full-time people, but most of the full-timers are like myself. We're not on the clinic floor all the time. We have a lot of volunteer faculty, doctors who are in the community like you, who because they like teaching will volunteer a half a day or a day a week or maybe even more. How much they get for it? They get nada, but they can say, I'm on the faculty at USC. But they enjoy teaching. So you call over your instructor, and your instructor, who's a dentist in private practice, will give the injection. And it usually works, but if it doesn't work, they give a second. Again, we would like the student misses two, stop, call over the instructor. If the instructor has a problem after two, then call somebody who is a specialist in anesthesia. In other words, we have a department of anesthesia and medicine. I'm the only full-time faculty. We have a whole number of people who volunteer to come in a half a day a week, a full day a week. So you call one of us over. Our specialty is anesthesia. So I kept this record. This is my personal experience helping students. Remember again that the patient has had 4 injections by this time. Okay. These are percentages over the years. The gray are maxillary. 5%, these are percentages. 5% of the time when I get called down to the clinic, the problem is a maxillary molar. 2% maxillary premolars, 2% maxillary incisor or canine. Now, I'll tell you right now, in every one of these cases, the doctors and the student gave infiltrations. I come down to the clinic, no magic involved here. I do a PSA for the molars, I do an ASA for the anteriors, and I walk away, and you know what? The patient's numb. They're numb. Easy. 5, 2, and 2 equals 9. 9% of the time, the problem is a maxillary tooth. I love when I walk into the clinic with a maxillary tooth as a problem. You know why? I'm going to be a hero in the eyes of that patient very soon. I am going to get that patient, I'm going to give the injection, I'm going to walk away. I'm just going to walk away and say, you know what? Call me if you need me. And they never call me. Because it works. PSAs and ASAs work. 9 out of 10 times, it's a mandible. Now, I want to show these numbers on the right-hand side of the screen are the important ones to you. 0 problem with mandibular anteriors, 0 problem with mandibular premolars, 0. See, what I'm saying to you now is, if you in your private dental practice have had a patient where you could not anesthetize the mandibular incisors, canine, or premolars, you did the wrong injection. You know what you did? You gave I'll use the term mandibular block. You gave an inferior alveolar nerve block to get the mandibular anterior teeth numb, and you didn't have to do it. You don't need mandibular block. I don't like that term because it's not the right term. Inferior alveolar nerve block. You don't need to do it to get the mandibular anterior teeth numb. And I'm going to give you the technique, and I guarantee, just listening to me and watching the DVD, and even better if you buy it, but, watching it, listening to me, if you simply do what I show you right now, I will guarantee it's going to work. Unless the anatomy in the mandible of Guatemalans is different. We have a hole right there, right below usually the second premolar, called the mental foramen. You've got it. It's there. Okay, see, the problem in the mandible, well, look, 0 here. 91% of the time, it's mandibular molars. I think any doctor in this room who has been in practice for a long enough period of time will agree with me that when you have a real problem getting a patient numb, real problem, it's always mandibular molars, always. And in fact, this is one of my favorite poses in the clinic. 3 hours after I went to the clinic to help a student, they gave 2, you gave 2, I gave 10. Oh, interesting question, and I'm not going to go into it. How many injections would you give somebody before you stop? Huh? In other words, you're really having a problem getting this patient numb. It'll be in the mandible. How many are you going to give before you say to yourself, that's it, I've tried everything, go home? And you know what's funny about this? Because this patient is a patient of yours for 30 years, and you've never, ever, ever missed. Today they come in, nothing. Can't get them numb. You know what's going to happen? They come back in next week, you'll get them just like that. What happened today? I don't know. Maybe there's a full moon. You don't know. I mean, things happen. You're having a bad day. He's having a bad day. You're both having a bad day. Send them home. But the question is, how much anesthesia would you put in before you stopped? Because I get involved in cases where they didn't. And what happened eventually was a seizure, convulsion, and what happened after that was the doctor did this. And what happened to the patient is he died. Now the doctor did not literally do what the doctor did was nothing. Oh, some doctors did something. Some doctors, I don't have a chair here, cardiac seizure leads to cardiac arrest. They call the emergency people. When they arrive in the dental office, they find the doctor and staff sitting in chairs crying. Nobody doing CPR. No, they're just crying. Another case, when they called 911, American 911, they found the doctor and the staff standing over here in the corner of the room, praying. The patient is dead. You know, at what point do you say to yourself, enough is enough? Keep that in mind, okay? Remember, these are the safest drugs in all of medicine for pain control, but they're drugs. And most problems with all drugs are dose-related. The more you give, the more likely you are to see the problem. Keep that in mind, okay? Mandibular molars are the problem. Now, the reason. The reason is bone. Now, I am not discussing children. Children are fantastic. Children, mandibular teeth are easy to anesthetize. Why? They're younger. And if they're younger, the bone is thinner. Basic rule, if the child has primary teeth only, they do not have any permanent teeth yet, all they have is 20 primary teeth, mandibular infiltration works. It works. We do not give blocks. When a kid is under general anesthesia, we do a nerve block. But when a kid comes in, he sits in the chair, we will do mandibular infiltration anesthesia on primary teeth, assuming there is no permanent tooth in the patient's mouth. As you get older, of course, the bone begins to get thicker. And what we find is when they begin to get into a mixed dentition, infiltration doesn't always work. Now, I have a problem with doesn't always work. This is a good kid. This is a well-behaved, he loves going to the dentist. Always had good experiences. What is the best way to make a good child into a dental cripple? Hurt him. And if I give him a mandibular infiltration and it doesn't work, you don't just say, sorry, the kid is now hysterical. The kid is afraid of going back to the dentist. So we switch to nerve block anesthesia once we get into a mixed dentition in children. And again, the reason is the cortical plate of bone in the mandible gets too thick. That's the problem. Well, we have some things to discuss. I won't discuss all of these with you right now. I will go over the inferior alveolar nerve block. This is the injection that I would, if I could get down on my knees, which I can, but then stand up, which I can't, okay? I used to be able to do that easily. Now I can't. So I'm not going to get down on my knees unless it's exactly lunchtime. Then you have to help me stand up. But I'll discuss a couple of these techniques. But the incisive nerve block is the one I really want you to listen, and I want you to do it. Okay, you can do this, I guarantee. You're going to be here today, tomorrow, and Friday. Monday in your own dental surgery, if you do this injection, it will work. 5 mandibular anterior teeth. Inferior alveolar nerve block, the traditional injection. And it is not a mandibular nerve block. I'm getting into technicalities here. But the inferior alveolar nerve, the one that you are blocking, is only a branch of the mandibular division of the trigeminal nerve. So technically, it is truly only an inferior alveolar nerve block. You're not getting the entire third division of the trigeminal nerve. Long needle. Long needle. Got to use a long needle. Why? Average adult has 20 to 25 millimeters of soft tissue. Long needle, 32 millimeters in length, short needle, 20. And you don't want to go all the way into the hub. You don't want to do that. We're going to use a long needle, and we're going to give almost the entire volume of anesthetic drug. Now, one of the most important things on this injection, and it is for every injection, before you give an injection, well, let's go back a little bit. You've heard of a neurovascular bundle. You have a nerve, artery, and vein that run together. Okay. If I am depositing local anesthetic by the inferior alveolar nerve, and I deposit the anesthetic in the soft tissue, it will diffuse and it will hopefully get into the nerve. But if I put that needle into the vein or into the artery and inject the local anesthetic, the patient won't get numb because the drug will be taken away by the blood, obviously. They won't get numb. But worse than that, they might have an overdose because I'm giving the drug intravascularly. So what we do before we give any injection anywhere, intramuscular, in the patient's mouth, you aspirate, right? You aspirate. Before you put the drug in, you take your finger and you pull back just a little bit on the plunger, and you're looking for red. You're looking to see if blood comes back in. And if blood doesn't come back in, you say, that's a negative aspiration and I can give the drug. Well, I'm telling you that's not true. If you aspirate and see nothing, that is not a guarantee that you're not in a blood vessel. Think about something. The needle has a bevel, doesn't it? A bevel. Okay. If I hold a needle, a syringe, here in the air, and I aspirate, what are you doing? You are sucking into the needle whatever is sitting outside the needle tip. So if I'm standing here, I'm sucking air into my syringe. And what am I going to see? I'll see air bubbles coming in, correct? Okay. I'm in the patient's mouth. I'm in muscle. I aspirate. I am sucking the muscle into the needle, which occludes the needle. Nothing comes back in. That's a negative aspiration. So far, so good. Here's a blood vessel. I put my needle into the blood vessel. I aspirate. Blood comes back in. So far, so good. It's easy. Now, I take my needle. Now, I can't see where I'm going. I'm doing this injection. All injections blind. I go in. I aspirate once. It's negative. I aspirate once. It's negative. I inject the drug. The patient has a seizure. I gave the drug intravenously. Following a negative aspiration, here's the reason why. Here's the bevel of my needle. Make believe this is the inside of the vein. This is the vein wall. My bevel of my needle could be sitting inside the vein with a bevel against the wall of the vein. I don't know. Now when I aspirate, what am I doing? I'm sucking the vein wall into my needle, which obstructs the needle, and no blood comes back. Aha, that is a negative aspiration. So now I give the drug. When I start to deposit the anesthetic drug, the fluid forces the vein wall off the needle, and now following one negative aspiration, I've given an intravenous injection of the drug. So on all the slides and all the video, it'll say after negative aspiration times 2. Here's what I'm doing. This is the palm of my hand. It's the bevel. Okay, I go in, and it doesn't matter where the bevel is. Here's my bevel. I go in. I aspirate once. It's negative. Before I give the injection, I take my hand, and I either rotate it a little bit down or a little bit up. I change the bevel orientation. I don't go in or out. I just either down or up. So when I say to you negative times 2, aspirate, negative, negative, then I give the drug. And that will guarantee that you're not inside of a blood vessel. Okay? IA nerve block. Of all the nerve blocks we give in the body, and I, as an anesthesiologist, I used to, back in the hospital, I used to do spinals and epidurals and caudals. And by the way, when you are pregnant and are going to have your baby, the word is epidural. The greatest word in the world. I want natural childbirth. No, you don't. You may want natural childbirth now. Never mind. Epidural. Local anesthetics are fantastic drugs. Fantastic drugs. This injection, this one, inferior alveolar, the one which we do more than any other, except for infiltration, the one that we do more than any other, of all the nerve blocks given in the body, has the lowest success rate. The lowest success rate. In experienced hands, I'm talking about one cartridge, okay, 1.5 mLs approximately. 85 to 90% success would be good, which means you're missing 1 to 2 patients out of every 10. And if you wait 3 to 5 minutes, and if you wait even longer, you're wasting even more time. You wait 5 minutes, John, you getting numb? Nope. Go back and do it again. Okay, it's a problem. And the problem is the anatomy here, there are very few good landmarks. In fact, there are no good landmarks here. The patient opens her mouth and you see this flat area of pink. There's no arrow in there. There's no triangle in there. I was in dental school back in 1965 to 1969. There's a reason for those years being important in a moment. My instructor said, on this injection, place your finger here and do this, and then put the needle in a patient's mouth at the apex of the triangle. Now, some of the doctors in this room may have gone to school and had that taught to them. You deposit at the apex of a triangle. Folks, I do not know what my instructor was smoking, but it wasn't a cigarette. I have been looking inside patients' mouths for 33 years. I have never seen a triangle in that patient's mouth. Never. Give me a break. You know, Dr. Timothy Leary, the guru of LSD, okay? Maybe he's the one who saw, turn on and tune out. You hallucinate. Nobody who is not on drugs can see a triangle in that patient's mouth. How the hell can I give an injection? I'm in dental school. See, dental school's easy. Well, it's not easy, but dental school for this is easy because if I am a student and if I have a problem getting a patient numb, I turn around and I have my instructor. You have somebody there willing and able to help you. You know what? In your own private practice, if you can't get a patient numb and you turn around, there's nobody there. Students, dental students as a rule, honestly, do not appreciate the importance of local anesthesia while they're in school. Because you always have somebody there to bail you out. It's when you're in your... you're going to graduate, whatever school you go to, you are going to win the award as the hands god or hands goddess. You have hands of gold, which makes doing dentistry kind of hard. But, you're the best there ever was. And if you can't get your patient numb, you can't do anything. Right? So you want to, again, for the students who are still here, okay, learn it in school. Learn it, do everything, whatever they let you do in school. If you can do a PSA and ASA, if they let you do it while you're in school. Okay? So let's go over this injection. The problem is we can't do infiltrations. We can't. Because the bone is too thick. So we are limited. We have to deposit the local anesthetic along. Let's go back to the dynamite stick and the fuse. This is the fuse. This is the fuse, and up here is the dynamite, the brain. The traditional inferior alveolar nerve block, it's called the Halsted approach. William Halsted, a medical doctor, in 1886 gave the first injection ever of a local anesthetic drug. He gave cocaine with adrenaline in 1886, and he gave an inferior alveolar nerve block. And ever since then, this is the injection we're teaching. And what we're doing is aiming to deposit the anesthetic at the mandibular foramen, at the point at which the nerve disappears into bone. That's the technique that has this 85% success rate. And you know why? Anatomy. Some people, remember bell-shaped curve? The foramen could be lower, which is good, because if the foramen is lower, the nerve is still sitting in soft tissue longer. But you know what? 15%, the foramen is higher. The nerve disappeared into bone too soon. And you're doing the injection the way you were taught in dental school. So you're injecting down here, but the nerve isn't there anymore. The nerve is buried in bone. And by the way, you've learned this in your clinical experience, haven't you? You, the doctor in private practice, have you been doing thousands of these injections, thousands of them. And you do it the same way every time. You put your finger, I don't have to name a landmark. You know what you're doing. And you put the barrel over here, and you look and you find your landmark. And you go into your contact bone, right? And most of us, assuming you're using a long needle, okay, when you contact bone, you look at how much needle is left in the patient's mouth, and you say to yourself, that's right. In other words, you know when you go in a certain depth, you're in the right spot. And you know that when you go in and you're on bone too soon, and you'll see this, you're not in the right spot. You'll learn from experience, but there are times when you go in and it feels right. And most of the time it works when it feels right. You've gone in 20, 25 millimeters, and it works. But today, nothing. Not even a tingle, not even anything. But it felt right. So you look in the patient's mouth for the dot, the puncture, the dot. Well, if that felt right, but I got nothing, then the nerve isn't there. It must be in bone. So you're going to go back and do it again. And the thing you did differently the second time was you went higher. Same anterior, posterior plane, but you went higher. I don't care whether you went in 5 millimeters higher or 10 higher, didn't matter. It worked. What happened was the nerve disappeared into bone on that patient too soon. Higher is better. That's the phrase. Higher is better. So now we have two injections. We have the Akinosi Vazirani, closed mouth mandibular, comes to the oral, to the endodontist office. See what happened? Can you understand me? Okay, I'm saying with clenched teeth for the translator's benefit. The patient comes to me, the general dentist, with a number 31 that's been killing him. I'll take care of it for you. I'm Malamed. So I go in and I give him one. Nothing. Give him another one. Nothing. I didn't write the book. Some other Malamed wrote the book. Oh, I'm doing left-handed. That's why I missed. Okay. I'll find an excuse, okay? See, Americans never take the blame for anything we do. It's always your fault. Keep that in mind, okay? I give 3. I give 4. I get a little bit of anesthesia. So I start to treat the tooth. So I start doing PDLs. I start doing intrapulpal. And he's writhing in pain. Eventually, I succeed in taking it out, getting the pulp out of the tooth. Okay, I send him home. Now, I've given him 6 inferior alveolar nerve blocks. I have stuck needles into that mouth 6 times. 6 times 1.8 is 10.8 mLs of fluid. I have distended the soft tissue back there a lot. I've damaged it. He goes home. He's talking. Numbness goes away. He's eating. Goes to bed at night. And for the next 6 to 8 hours, does nothing. Now, I run every day. And I get up at 5 o'clock in the morning where I live. I live 30 miles from USC. And I get up early in the morning, and I sometimes run at home before I leave my house. I used to have a little Alfa Romeo sports car a long time ago. I would get in the car, I ran 6, 8, 10 miles, get in my car, drive an hour to go to school. In that hour, the muscles, which I've been running with, tighten. You ever get a cramp in your leg? Okay. I sit in the car and I get out of school an hour later and I can't even stand up. The muscles go into spasm. What happens to our patient? We stick needles into his not his masseter, but the medial pterygoid 6 times. We stretch the muscle. 10.8 mLs of anesthetic. He's talking, he's eating. He's using the muscle. There's no problem if I walk around. But if I sit still or if he closes his mouth at night, the muscle goes into spasm. We call that trismus, don't we? Trismus. Oh, by the way, his tooth blows up on him. So he comes back in the morning to you, the general dentist office, and says, "Doctor, you've got to help me. This tooth is killing me. I can't. Oh, please help me." And you happen to be lucky because visiting you that day from Australia is Dr. George Gow-Gates. George Gow-Gates invented a technique of mandibular block anesthesia. And George passed away 5 years ago, but a very good friend of mine. I have seen George Gow-Gates do this injection in hotel rooms that you couldn't even see in the patient's mouth. You know why? It's his technique. He's done it literally blind. Okay, now, so George Gow-Gates comes in and says, "Don't worry." And the first thing he says is, "Open wide." In the Gow-Gates technique, you have to open wide. And the patient opens 3 millimeters. "Well, Dr. Gow-Gates, go ahead, demonstrate your technique." When does a flight to Sydney, Australia leave? Doesn't work, does it? How on earth are you going to give a mandibular injection, help that patient with tooth number 31 when you can't get in? The Akinosi-Vazirani technique is a closed mouth injection. It was designed for people with trismus. It's intraoral, but it's done on the outside of the teeth. Now, I'm not going to show it to you, but the reason it's a good injection, and again, endodontists, oral surgeons, people, general dentists who do a lot of emergency care, this is an injection worth learning. And the reason it's good is very, very simple. The third division of the trigeminal nerve, the mandibular division, is sensory and motor. Motor. It is motor to the muscles of mastication. Trismus is spasm of the muscles of mastication. See, when you do an IA nerve block, when you do a Gow-Gates, you're blocking the muscles to the muscles of mastication, but it doesn't matter because there's no problem with them. But when you have trismus and you block them, the mouth opens. And that's why the Akinosi technique for some of you in this room is worth learning. It opens the mouth. It also gets them numb, but I don't even care about that. It opens their mouth. See, if it opens their mouth and they're still in pain, I could do stuff. I could do IA, I could do Gow-Gates, I could do. But when the mouth is like this, I can't do anything. That's the Akinosi. It's a little bit higher than the traditional inferior alveolar. And then we go to the Gow-Gates injection, which is aiming for the neck of the mandibular condyle. It's George Gow-Gates saying to himself back in 1948 in his dental office in Sydney, Australia, that if the most common reason for missing, the reason we miss the inferior alveolar nerve block is because we deposit the drug too low. The nerve is gone, it's in bone. And if I go up a little bit, it works better. If a little bit higher is a little bit better, then why are we starting down here in the first place? What is going on here? Why are we aiming for the place where the nerve goes into bone and disappears? Why not aim somewhere higher where we know that in everybody that nerve is still sitting in soft tissue? As long as that nerve is in soft tissue, you can get it. And he uses the neck of the mandibular condyle. And this is not the inferior alveolar nerve. This is the entire third division. You don't have to give, it's amazing. Inferior alveolar nerve block doesn't hurt. This should not be more than a 1, maybe a 2 maximum, the IA nerve block. But then we have to give that ridiculous long buccal. I don't say ridiculous. I have a problem with the term long buccal because there's no short buccal, the buccal nerve block. But when you give that buccal nerve block, that hurts because you're on periosteum instantaneously. In the Gow-Gates injection, you don't have to give it. It gets the entire thing for you. So here's the inferior alveolar. Reality, as I mentioned earlier, you go in, you experience of 1 year, 10 years, 20 years, 30 years. You go in, you contact bone. And I'm hoping you contact bone because I know a lot of doctors who don't contact bone in this injection. I got a problem with that. I have a real problem when you don't contact bone. And I'll show you one reason why you should contact bone. But contacting bone gently doesn't hurt. See, I said that touching bone hurts. That's not true. It's how you touch bone. It's not bone, it's periosteum. Bone doesn't hurt. You can operate on bone without any anesthesia. In fact, we do craniotomies. We do surgery inside the brain without any anesthesia at all. The only unconscious people. The only anesthesia you need to get into the brain is local anesthesia of the scalp. Think perio, okay? You're going to do a flap. You're going to do osseous surgery in perio. The only anesthesia you need is to get the soft tissue to reflect the flap. Once you start working in bone, it doesn't hurt. Anesthesia of the scalp. Just like perio, you now reflect you scalp the patient. You simply pull the scalp back. Everything else you do with the drill to remove the cranium doesn't hurt. Working inside in the brain is painless. Doesn't hurt at all. So, you go in, so back to the periosteum. If you touch bone with your needle tip at a right angle like that, that doesn't hurt. What does hurt is when your needle is coming in parallel to bone and you scrape along it. Now, I don't know what you were taught, but here's what I teach. Bevel towards bone. You've heard that? Bevel towards bone? The reason, again, is all about comfort, not anything else. Bevel towards bone. If my bevel is facing the bone on a maxillary infiltration, okay, where you shouldn't be touching bone, but accidentally you're too close. If my bevel slides along the periosteum, the patient, makes that face, but it doesn't, it's a 3. Now let's turn it around so the bevel's facing away from bone, which means the sharp needle tip will tear periosteum. That's a 10. That's the only reason for bevel towards bone. That's the only reason right there. So you go in, you give the injection, you go down to your contact bone, you see how much is still visible. If it feels right, 20 to 25 millimeters in the average adult is 2/3 to 3/4 the length of your long needle. You say to yourself, this is right. You aspirate once, you aspirate twice, and you give the injection. And invariably, it's going to work. If you go in with your experience and you contact bone, I'm going to say to you, less than half the length of a long needle. Average-sized adult, and you contact bone on the inferior alveolar nerve block, half the length of a long needle, you're not in the right spot. Where are you? You're too anterior, you're too lateral, you're too anterior. So what do? You don't pull it out and start again. You pull the needle back a little bit. It's still in tissue. You pull back a little bit and you aim your needle tip more posteriorly. You go back into your contact bone at a more appropriate depth, aspirate ×2, and you give the injection. The third one is one that I got in trouble with when I was in the U.S. Army back in, it was the American Civil War, 1865. Now, I was there in 1971, 1973. And a general, I was a captain in the U.S. Army Dental Corps, and a general came in who's a serious soldier. Generals are serious. And the guy came in, and I was Captain Malamed, and I had done anesthesia residency. So, I'm a general dentist, and I was giving him an injection. And I go in, sir, open your mouth. Opens his mouth, and I go in. Did you ever have a patient where you really can't find bone? And you're going in, and you honestly think it's going to come out. It's not going to, because the distance from where you puncture to here is more than 50 millimeters. Your needle's only 32, so it's not going to happen. But it's going to go somewhere. So I was doing everything. You go in, and you can't find bone, you pull back, and you start, the old, I'll get it eventually, And I gave him the injection because I'm Malamed, See, what happens when you're young, you really believe you're good. And that's when you get in trouble, And I went in and I gave him, I aspirated, did everything right. Sir, are you getting numb? No, Captain, but Captain, I can't close this eye. Excuse me, sir? You see this eye? See, closing? Can't close my eye. Are you numb, sir? No, I can't close my eye. No anesthesia. No. And I see his upper lip is drooping. Oh, Lord. So I'm saying to myself, okay, wait a minute. I did not go to every lecture. Shh. Now, dental students, do not listen to this. I did not go to every lecture in dental school. Okay? Like many of you, I didn't show up. I slept in, whatever. I must have missed this lecture because think of this, unilateral muscle weakness. The general's having a stroke. He's having a cerebrovascular accident, unilateral muscle weakness. Oh my God. So I said to him, sir, squeeze my hand. Ow, ow, ow. Oh, good. No stroke, good. But I had no idea what's going on. No clue. So I walk outside to my commanding officer, Colonel Mac Huey, oral surgeon, and I said, sir, I'm having a problem with the general. I can't get him numb. But something weird happened. His face is paralyzed. Mac Huey is an oral surgeon. He looked at me and he said, Malamed, don't you know what you did? Now, I'm thinking this. I didn't say it. Because if I said it, I'd be... If I knew what I did, why would I be here asking you? But I was smart enough not to say that. Isn't that true? If I knew what I had done, why the hell would I be wasting my time out here? What I did was simple. I deposited the anesthetic drug into the parotid gland. And I still didn't get it. What the heck does that matter? So the saliva is numb. What's the problem? Because the seventh cranial nerve, right? The seventh cranial nerve, the facial nerve, the motor nerve to the muscles of facial expression is in the parotid gland. I gave a lidocaine with epinephrine seventh cranial nerve block. One of the most useless, you tell me when you would ever on purpose want to paralyze the anterior part of the face. There is no reason ever, the most useless injection in the entire body, but I did it. Now this is not the general. This is a dental hygienist in Oregon, Portland, Oregon. And she came to my class. I gave a course on anesthesia. The morning this happened, she had been in her own doctor's chair. He did a procedure on her, and this is what happened to her. It's on her left side, right there. See? By the way, you know what this is? This is Botox. No. All honesty, botulinum toxin is a very long-acting local anesthetic. What they're doing is depositing local anesthetic in the muscle. They are paralyzing the muscle. The same thing would happen with lidocaine, but it would only last for 5 hours. Botox lasts for 6 months. It's a local, if you gave a botulinum toxin, if you gave a Botox mandibular block, seriously, it would last for up to 6 months. Now, there's no reason to do this, and the amount you'd use would be, they would die, but you could do it. Botox does that by injecting directly into the muscle. In other words, she has no furrows. She can't frown. She can't do that. She did this with lidocaine with adrenaline. This will go away. This will go away in 5 hours. But for those 5 hours, she can't close that eye, and that's the only danger here. If you're wearing contact lenses, when you blink, you are lubricating your eye. You're cleansing your eye. She can't do that. Out come the contact lenses, and on goes a patch. You have to have a patch on to protect the eye until the paralysis goes away. This is not a very good practice builder if you have this patients walking out of your office wearing an eye patch. Hey, do it bilaterally. Have to have a seeing eye dog, you know. That's the reason I say contact bone. That's the reason right there. This can't happen if you touch bone. Can't happen. Only if you don't contact bone. So here's another little trick. This is a trick I learned in the Army. Now, you have to listen to this carefully because you may not understand the fine point of this. After you finish giving an inferior alveolar nerve block, you sit the patient upright because it helps to speed the onset of anesthesia. Okay, let's go back and say it again, and then we'll explain it. After you finish giving an inferior alveolar nerve block, you sit the patient upright to help speed the onset of anesthesia. Okay, what I'm implying is they're not sitting upright during the injection. Right? If I say to you, sit them up after, that means they weren't sitting up during. Okay, let's go to that one. The most common medical emergency in dentistry is fainting. Fainting happens most often during injections. How do you treat faint? You lay the patient down. Guess what? If you never want to see fainting, how about laying the patient down before you scare them? They're afraid of getting shots. Lay the patient down. Place the patient into a supine position. They can't faint. They can't faint in a supine position. Supine is horizontal. They can't faint. So I'm laying my patient down for all injections in the mouth, all of them. On this injection, after we finish, we sit the patient upright comfortably. My experience in the Army was, because we were working with soldiers who were macho guys, 18, 20, they faint just like that. They see a needle, they're out. You lay them down, they get better. So we lay them down. And then some of the soldiers, some of the dentists at other dental clinics couldn't get the soldier numb. They sent him over to me. See Malamed at the hospital. The soldier had 2, 3, 4 injections, had no anesthesia whatsoever. They got up, came to see me 10, 20 minutes later. Invariably, they were numb. And what they said was, sir, I love that sir thing, sir, I had no numbness when I was in the chair, but within 5 minutes of standing up, I began to get numb. So now when I go to the clinic and it's a mandible, in the dental school, mandible problem, if that patient is still lying like that, I will not do anything. I will say to the student and their faculty, sit the patient up for 5 or so minutes, I'll be back. I come back in 5 minutes. Most of the time, they're busy doing dentistry at that point in time. It works. I can't give you an anatomical reason. It works. That's all you want to know. It works. Okay, let me show you this, and then I want to show you one other injection. We'll take our lunch break.
Anesthesia to the pulps of the 8 mandibular teeth in that quadrant. The buccal soft tissues and bone anterior to the mental foramen, the anterior 2/3 of the tongue and the floor of the mouth, and the lingual soft tissues and periosteum. A 25 gauge long needle is recommended. For a left inferior alveolar nerve block, the right-handed operator should sit at the 10 o'clock position facing in the same direction as the patient. For the right inferior alveolar nerve block, the right-handed operator should sit at the 8 o'clock position facing the patient. There are 3 criteria for determining the correct insertion site for the needle. The first is the height, the second is the anterior-posterior position, and the third is the depth of penetration. A finger is placed on the lingual aspect of the ramus and pulled anteriorly until the carotenoid notch is palpated. The carotenoid notch is the greatest concavity on the anterior border of the ramus. The barrel of the syringe is placed in the corner of the mouth on the opposite side. The needle tip touches the most posterior aspect of the pterygomandibular raphe. The needle tip is then moved half the distance toward the carotenoid notch and then half the distance back toward the raphe. This locates the injection site, which is 3/4 of the distance from the carotenoid notch to the raphe. The needle is then inserted and advanced slowly until bone is contacted. The average depth of penetration is between 20 and 25 millimeters, which is 2/3 to 3/4 the length of a long dental needle. Once bone is contacted, aspiration is performed twice, and if negative, 1.5 to 1.8 mLs of local anesthetic is administered slowly.
Okay, now bear with me for a second. I want to discuss this one with you, and then I have one video more to show you, then we'll take our break. And that is the incisive nerve block. This is the one I was going to get down on my knees for and beg of you to do. Please, if you are still in school, do this. Okay? You're taking advantage of a hole in the bone. The biggest problem we have in dentistry is getting mandibular teeth numb. I'm telling you right now that you're not going to have a problem getting mandibular anterior teeth. I'm counting the 5 mandibular anterior teeth: incisors, canine, and 2 premolars. Now, I'm telling you that with a 99.9% guarantee that if you do this injection the way you're going to see it right here, it will work 99.9% of the time. Of course, I'm lying. You know, there are always exceptions to the rule. But the 5 mandibular anterior teeth are easy. You're taking advantage of anatomy, the mental foramen. The mental foramen is usually located right below the apex of the second bicuspid premolar, usually. It may be a little bit more anterior. Now, if it's located right below the apex of the first premolar, you might not get the second premolar. You understand, right? What you're going to do is by depositing drug outside the hole and pushing it in, you're blocking the nerve right there. On this x-ray, you're going to have anesthesia of the second, the first, the canine, and 2 incisors, guaranteed. If that hole were a little bit more anterior, you cannot guarantee it's going to get the second premolar. So you look on your radiographs for the hole. It's usually right by the second premolar. To make it really easy, all you're doing is an infiltration. Same thing you do in the maxilla. In the maxilla, you're infiltrating anesthetic above the apex of a tooth. In this injection, you're infiltrating anesthetic outside the metal foramen. Now listen carefully, outside the foramen. You're not going to touch bone. You're not going to go into that hole. You're not going to go in the hole. You are doing an infiltration. You're depositing local anesthetic outside the mental foramen. That's the mental nerve block. The lip is numb instantaneously. You don't care about that. It's just like the infraorbital. You don't care about the infraorbital. But just like the infraorbital, to make the teeth numb, you did this, right? Well, you know what? To make the mental nerve block into the incisive nerve block, the nerve that is inside that bone is called the incisive nerve. You push. Same exact technique. Infraorbital becomes ASA by pushing. Mental becomes incisive by pushing. That's all you have to do. Now, how long do you push? Minimum 1 minute, preferably 2. What you're doing, of course, is forcing anesthetic into this hole, and you're blocking nerve conduction right there. Everything you do anterior to that hole, you got. No pain whatsoever. Easy injection to do.
The incisive nerve block provides pulpal anesthesia to the 5 mandibular anterior teeth, the incisors, the canine, and 2 premolars, the buccal soft tissue and bone anterior to the metal foramen, and the skin of the lower lip and the chin. A 27-gauge short needle is recommended. For the right or left incisive nerve block, the barrel of the syringe is kept below the patient's line of sight, and the needle inserted into the buccal fold adjacent to the first premolar, and then advanced until the needle tip lies outside the metal foramen. Following 2 negative aspirations, 1/3 of a cartridge of anesthetic is deposited over 20 seconds. The syringe is removed and pressure is applied extraorally or intraorally, forcing local anesthetic into the metal foramen, blocking the incisive nerve.
You need 1/3 of a cartridge in an adult. Now, if your patient's a child, this is a fantastic injection. If you're going to be treating multiple teeth in the child, the mental foramen is found by the second primary molar. By putting in 1/4 of a cartridge on the child and pressing, you will get anesthesia, maybe not of the entire second primary molar, but guaranteed of the first and the anterior teeth. Very nice injection again. In adults, 1/3 of a cartridge. In children, 1/4 cartridge. The most important aspect of this injection is the finger pressure that you apply. I have one last thing for you before we break for lunch.
Zazu condoms. Fun, sexy, safe.
Okay.